I would like to welcome you all to this webinar on social prescribing. My name is Susanna Althini. I'm a general practitioner and I live my life on Gotland, Swedish big island in the Baltic Sea. And today I'm at my local healthcare center in Slite. This is the furthest east in Sweden you can come. And before this webinar, I've been to our team rehabilitation team where we work together to find ways to help people feel better, focusing on mental health often, but also other issues. I've had a special interest in social prescribing since 2018. I went to London to visit the British Society of General Practitioners, and we also visited Sam Everington's community center in Bromley by Bow. And this was sort of an epiphany for me, that because we went to London to discuss how can we work with lifestyle habits with our patients. But here in Bromley by Bow, I saw something broader, something more holistic, and it was focusing on the social determinants of health. And social prescribing is medical language, and this is a clue to what we will discuss today. And I think it's very important to link the primary care to the local community and all the resources out there, because only 20% of causes of feeling not good are medical reasons, and the rest are things in life, concerns, problems, loneliness, all kinds of things. And here in Slite I have a note here, and we have a collaboration with Grown Up Education Association. So this organization arranges groups, feel good with crafts, feel good with movement, and feel good with cooking. And our patients can join this group. And we also have this association is working close to us to take care of people who we want to hand over. And we also have a social educator working with us within our organization, close to nurses and doctors. And together we can help our patients to solve problems, making them not feel good. And it's really, I'm really looking forward to this webinar today, and it's also very nice to hand over to Sam Everington, who's the next speaker. But his presentation is recorded because of late coming problems in his life. So he has recorded his presentation, and it will be time for that in just 1 minute. But I would also like to say something more about infrastructure for person-centered care. We are working very much with regular contacts in healthcare and social care here on Gotland. We are defining these roles and making them visible in our digital records, so that it would be easy for me as a regular GP for a person to see that this patient also have a regular contact, like in in the oncology department. So keeping things tied together so that we can work together in a person-centered way. And this is important for me as a doctor. And it's also important to have a connection to the local resources in the community. And this is where the link worker comes in. It's a very important link in the infrastructure for social person-centered care and social care, healthcare and social care. So with this introduction, I would like you to start Sam Everington's presentation.
Thank you. Welcome, Sam Everington. The floor is yours, please.
So in a few moments, I'm going to take you around our Bromley by Bow Centre in the East End of London, and also give you some other examples of social prescribing in this country and now around the world, because it's become an international movement. But first of all, I wanted to start with an oversight of actually what the problem is, because that helps you focus on some of the solutions. One of the first examples I'll give you is the massive difference between obesity in countries like England and Japan. Really, you're looking at 3 to 4 times the rate of obesity. And what's the secret to dealing with this? Well, the answer is it's a social prescribing approach in Japan, which means that every child in Japan gets a healthy school meal. They don't get chips. And one teacher is designated to have extra training to teach on nutrition. And you will talk to Japanese children and they'll tell you what fans they are of broccoli. Now, that would not happen in the East End of London. Now, when you look at the comparative data between Scandinavia and the UK is so much worse in so many of the health statistics. But actually, we can't sit on our laurels, and I speak as a half Norwegian myself, because although the statistics in Norway are good at this moment in time, actually it's now the pizza capital of the world, eating 11.4 kilograms per person per year. So we have to constantly ask ourselves, what's the problem now? But actually, what are we storing up for the future in terms of problems? When you do a comparative data of antidepressant use, really interesting, Scotland and Norway, the same size countries, very similar in terms of its geography, its forests, its mini fjords. But actually you see here that we're talking about 3 to 4 times the use of antidepressants, and interestingly, no difference in the suicide rate. We need also, in the social prescribing movement, to think about the challenge we give to traditional biomedicine. And we must never forget not just the story about antidepressant use, but the fact that over 10% of over 65-year-olds admitted to hospital in the UK are as a result of drug side effects. So social prescribing is not just useful in terms of tackling the issues thrown up by the side effects of biomedicine, but in itself, it's absolutely vital to provide holistic healthcare to the whole of our population. And we often say that biomedicine is really only 20% of people's health and well-being. The other 80% I'll define to you in the projects that we do at Bromley by Bow. In the UK too, a really horrifying statistic is that by 2040, that's 15 years from here, if you live in a deprived area, you can only expect 50 years of good, healthy life. If you are well off, it will be 70 years. And that is all about lifestyle. It's very little about traditional medicine. And of course, as I said before, this has become a massive movement across the world. 5 years ago, I persuaded the government in England to put social prescribing in every practice. We've got over 3,000 social prescribers now in the country, and this now has taken off over the world. We have 3,000 visitors who come to the Bromley by Bow Centre every year, and invariably they go back and they create some amazing projects in their countries. Singapore, Sweden, France, all these countries I've visited and done lecture tours in the last 2 years. And I always start my lecture by asking all the audience actually to stand up and talk to the person next to them and just ask the simple question, what makes you well? And I can tell you what the answer is. It's never about a hospital, a doctor, or drugs. Now, what is really interesting too is the research that's emerging from social prescribing is its powerful impact actually on reducing pressure on healthcare services. And yes, this is probably one of the best pieces of research, but it's cutting general practice consultations by 40% and over 20% attendance in accident and emergency in hospitals. Social prescribing is powerful medicine, not just for the individual, but also for the health service. And this is a fantastic piece of and fascinating piece of research, which took us a bit by surprise in that we asked doctors and nurses about social prescribing, and 95% of them believed that it improved the well-being of their patients. But what was a slight surprise to us is that 98% believe social prescribing brings well-being to them as a professional. So it's a win-win all way round. Now, this is 20 years ago in the centre of London when I was at the British Medical Association headquarters and the leading doctor there, and we had to deal with the casualties of the bus bomb, which went off straight outside the building. And I realised then actually the importance of primary care in bringing communities together. All of our Scandinavian communities have issues around integration of different ethnic groups. And this is a typical picture at Bromley by Bow and takes people a bit by surprise when I say it's very normal for different communities just to be sitting down and talking to each other. But it was a really important message for me when I had to manage the bus bomb, because I was terrified of the consequences of bad feelings in the Muslim against the Muslim society. And I was able to go on TV that night and talk about Muslim doctors who'd worked hand in hand with me to actually save the casualties. I'm now going to take you in and give you a taste of the Bromley by Bow Centre. And of course, this is the National Health Service, but you wouldn't think so looking at that arch, which is a joint project with one of our big supermarkets who paid for the restoration of the arch. And I, of course, said to them, well, what can I do for you? And they almost looked at me, well, what could you possibly do for me? And of course, what we did was help get them to think about the foods they needed to provide in the local supermarkets, particularly for some of our Bangladeshi and Somalian patients. And cheekily, I said a year later, thanks for the 20,000, how much do you think I gave you? But the message behind this is that if you are to achieve success in social prescribing, it's got to be a real partnership between the patient, the private sector, the National Health Service, the church, and charities. And of course, when you come into the arch, through the arch at Bromley by Bow, you see fantastic art. And of course, we have 3 art studios here. These are artists actually who sell their art. That's their business, but also they're a critical part of the social prescribing, the art therapy that we provide for patients. And of course, a fountain designed actually to help patients relax. This is a group that started life around sorting out leg ulcers. It was a leg ulcer and flower arranging clinic. And now, because we've got rid of the leg ulcers, it's now the Young at Art, and they're doing all sorts of fantastic artwork. And of course, you come into the centre and it doesn't look like a traditional health centre, does it? Because there's lots of wood, it feels warm. I always say the infection control police would say you shouldn't have any of that, but actually they ignore the importance of mental health. All they can think of is bacteria. And of course, critical is how you behave as a doctor and how it changes the way you behave. And this is about working in partnership with patients and a new idea of not focusing on what the matter is with them. Have they got diabetes? Have they got heart disease? But what actually matters to them. And once you start turning that phrase on its head, actually you get far better outcomes for patients. And of course, we have the Olympic site just down the road. So we set up Paralympics. The woman on the left is the stone sculpturess. That actually was at a party where we invited 15,000 of our patients into the park where we sit, which we run, to a party. And yes, they had their blood pressures measured. They had face painting, but what a joyous celebration. And what we like to do at Bromley by Bow is celebrate. Our motto is fun, friendship, compassion, and assume it's possible. And of course, getting a job is absolutely vital. There are 1 million of our young community aged 16 to 24 who do not have a job and are not training for anything. This is disastrous. We call this deconditioning. And so actually one of our key projects here is our job advisor, and our key emphasis is getting people into work. In fact, the 80% of health we define as sorting people's finances out, their environment, the creative side of their life, a job, and education. And of course, Fatima is key to this. She's been with us over 20 years, knows all the Bangladeshi community, and she set up this project called Grannies in the Kitchen, and she runs a regular walking group. At the front of the cafe is our welcome zone. Our social prescribers hang out here. And you can come in and have a cup of coffee, you can use the laptop, or you can go into one of the tiny consulting rooms and talk about something very confidential. Anything you like. And this is also where the doctors send their social prescribing referral form, which probably takes about 30 seconds to complete. And it has boxes that you can tick, which might include loneliness, finance, all sorts of things. And then the social prescribing team kick in and really focus on what it is that the patients are worried about, what will make them better. We are, of course, a community university, so we run all sorts of training courses. We started life as a church at Bromley by Bow, and in fact, this is my wedding 12 years ago. This is Lord Mawson. He's a politician in the House of Lords now in England. On the back of all the amazing work he did on social prescribing, he's the founder of the centre. He and I love champagne, and of course, why would we not serve champagne from the altar at the end of the wedding ceremony? Amazing group here that we supported 20 individuals who'd never public spoke before and never developed a project. We supported them over a few months to set up their own amazing projects. And then they had to come in front of all of us, 200 of us sitting behind here. And there was £1,000 prize for the best project. It was amazing. And I was ready to get my credit card out and give some money to some of the other groups. Even I didn't know that the company that had promised to invest had actually decided secretly they were going to give £1,000 to every single project. And a lovely moment where a young woman stuttered. She couldn't get her words out. She was nervous and terrified. And just the love from the whole audience and just seeing her then present her project and realizing what impact that would have on her life and the people in her project was amazing. And of course, this is one of our doctors running a course, DIY Health, teaching people about eczema, minor illness, reducing attendance in general practice and accident and emergency in hospital by 30%. And a project here of a GP friend of mine who is getting children, teaching them to grow food, eating healthy food. This is them coming down to London for the first time and presenting in front of an audience their amazing project. And of course, the College of Medicine, which I'm part of, Mike Dixon actually is a GP also, the guy on the left, you'll recognise King Charles on the right. Mike Dixon is the King's doctor, head of the medical royal household. And of course, if you look at his surgery, he's got a herb garden. And so there is examples of social prescribing across the country, all very different. And this is another example of a cafe staffed by mental health workers, open 7 days a week, amazingly, as a result, reducing acute admissions to psychiatric hospitals by a third. Isn't that amazing? And isn't that powerful medicine? And of course, finally, what's so important about social prescribing is the connection to nature, family, and community. And this is my family on the west coast of Scotland swimming. Yes, we fly the Norwegian flag there, but doesn't that make you feel well just looking at that? And of course, this is our Norwegian church in the East End of London on the 17th of May, the national holiday, in our bunad from Telemark. The connection to family, nature and community, absolutely vital to all of this, and possible even in the smallest community. And this is on the west coast of Scotland, where the local GP saved the local shop and post office, runs community taxi for people, elderly people, runs all sorts of community projects. It's possible anywhere. And of course, behind all this lies the team. This is my team a few years ago. And I always like to say to people, I'm not a brilliant doctor, but I am brilliant because of my team. So I'll leave you with that picture of Bromley by Bode and that sense of fun, friendship, compassion, and assume it's possible. And leave you with the message that whatever social prescribing you do, it is now one of the most powerful medicines and is the way we're going to reverse some of the appalling health statistics that sit in all our countries.
And from that inspiring talk, we go to Katie Muhl, who's going to talk about what is social prescribing, the definition.
Hello, everyone. My name is Caitlin Muhl, and I'm delighted to be speaking to you today at your conference. Today, I'll be talking about the findings from an international Delphi study that was conducted as part of my doctoral work to establish a globally agreed upon definition of social prescribing. So before I begin, I would like to take a moment to acknowledge that Queen's University and the place where I call home in the Niagara region here in Ontario, Canada, are situated on traditional Anishinaabe and Haudenosaunee territory. I just want to say that I'm very grateful to be able to live, learn, and play on these lands. And I would also like to recognize the close ties between social prescribing and Indigenous ways of knowing, being, and doing. So very quickly, a little bit about me. As I mentioned, I am based here in Canada, and I'm close to Niagara Falls. And since I completed my doctoral work, I have started working in a hospital here in Niagara as a quality and patient safety specialist. And what's really exciting is I'm actually about to embark on a social prescribing project here in the hospital, where we will have older adults who are presenting to our emergency department with social isolation and loneliness, being connected to a link worker to get them connected into our community. And so really exciting because this isn't something that we see too often happening in the hospital. It's pretty exciting for me to be involved in having this happen here in the hospital and particularly here in my own community where I grew up. And so I just want to kind of set the stage and say that it's a really exciting time for social prescribing. It is gaining traction globally. There's a huge social prescribing movement globally. And there's over 30 countries that are involved in this movement. And I just want to say how exciting that is to see that there are so many countries around the world recognizing the importance and value of this. And what I want to say as well, for me in particular, as a quality and patient safety specialist, I get really excited about the fact that social prescribing has the potential to impact all 5 components of what we call the quintuple aim. Now, this is an internationally recognized framework for optimizing health system performance. So this framework, it's used in countries around the world as a way to sort of guide the work we do to achieve high-performing, high-quality health systems. So what does this look like? This means that we need to enhance service user experience, we need to enhance provider experience, we need to reduce our healthcare costs, we need to improve population health, and we need to advance health equity. And what's really exciting is that the research shows that social prescribing has the potential to impact on all 5 components of the quintuple aim. And so it really truly is a powerful tool to advance health quality. Now, when I was embarking on my doctoral work, what I came across a lot in the literature was the fact that people were excited about this, they were talking about this, but there was no agreement on what social prescribing was. Everybody was defining it in a different way. And I found that really interesting and something that needed to be addressed. As I dug into the world of definitions, I discovered that there's actually two different types of definitions, conceptual and operational. So a conceptual definition tells you what a concept means, and an operational definition tells you how to measure a concept. And I realized that there was a lack of agreement on both of these types of definitions when it came to social prescribing. And so I decided, okay, I had to do something about this. And so my research aimed to develop internationally accepted conceptual and operational definitions of social prescribing. And so what I embarked on was a 3-round Delphi study that was conducted with an international multidisciplinary panel of experts. And that was really important. I didn't want this to be a study of just a group of Canadian experts or just very centralized to North America. I wanted this to be something that was really global. And so there was a really big emphasis on making sure that there was global representation in this panel of experts. And so altogether, we had 48 participants in the study representing 26 countries. And you can see that Scandinavia was represented in this study. And so what happened was the experts participated in 3 rounds that built on one another. And through those 3 rounds, consensus was achieved on both conceptual and operational definitions of social prescribing. And for those who have read the paper on this study, you'll know that there's long and short versions of the conceptual definition. For today, I'll just read the short one for you. So here is the conceptual definition. Social prescribing is a means for trusted individuals in clinical and community settings to identify that a person has non-medical health-related social needs and to subsequently connect them to non-clinical supports and services within the community by co-producing a social prescription, a non-medical prescription, to improve health and well-being and to strengthen community connections. So some really key aspects here. The fact that social prescribing can happen in both clinical and community settings, that there's this first step of sort of identifying that the person has this non-medical need, and then this second step of actually connecting them to a non-clinical support and service based in the community. Co-production is really big here. So the fact that the social prescription is co-produced is mentioned, and the fact that this is a non-medical prescription. And the idea being here that we are aiming to improve health and well-being and strengthen our community connections. So all of those pieces are really key and make up this definition here. Now, this is the operational definition, and as you can see, again, this is about measurement. How do you actually measure and identify this? So it looks a little bit different. So this one is that social prescribing is a holistic, person-centered, and community-based approach to health and well-being that satisfies condition 1 and either condition 2 or conditions 3 and 4. Okay, so condition 1 is that the identifier identifies that the person has non-medical health-related social needs, for example, issues with housing, food, employment, income, or social support. Condition 2 is that the identifier themselves connects that person to non-clinical supports and services within the community by co-producing a non-medical prescription. Now, condition 3 is that the identifier refers the person to a connector, and condition 4 is that the connector is the person who connects that individual to non-clinical supports and services within their community by co-producing a non-medical prescription. Now, what I want to note as well is that these definitions were transformed into the common understanding of social prescribing conceptual framework, otherwise known as the CUSP framework, as a way to sort of visually depict all of the different components of these definitions. So that's another resource that's available. Now, while it was great that we were able to come together as a global community and come up with a globally agreed definition, the problem that I was faced with as a doctoral student is that I knew there was a 17-year research to practice gap. And I knew that the social prescribing community could not afford to wait 17 years for the outputs of this work to be fully adopted in practice. And so I knew there was a need to get a little bit creative, think a little bit outside the box. And I knew that there was an eagerness to collectively promote the uptake of the definitions and framework by the social prescribing community. And so what came out of this was a collective commentary on the study, co-authored with over 50 authors from across the globe, including some who today might be at the conference. And so this really was a way to sort of promote this work, celebrate this work, get the word out there, talk about the use and utility of the outputs of this work, where we go from here, and as well some of the limitations of this work and some of those considerations. And so if you do have a chance, highly recommend you give that a read. What this work was kind of based around was the ADKAR change management model. So this idea that in order to effectuate change, we need to build awareness, desire, knowledge, ability, and reinforcement. And so the idea here was we were able to build awareness of the definitions and framework by having so many authors, so much interest by the global community in this paper. We were able to build the desire to use the definitions and framework. And the idea as well was to build knowledge of how to use the definitions and framework with some really tangible examples in the paper of how to use them. And so since the Delphi study has been published, it has been cited in over 150 academic publications. So it's really exciting to see that there has been this kind of uptake, and certainly it seems like it has been of use to the community since it's been published. What I found really exciting as well is to see the ways that it's been used in other ways. And so this includes, for example, the National Academy for Social Prescribing website, where they have a section on what is social prescribing, and you see the definition right there. There's also some great literature documents, including the report on social prescribing around the world by the National Academy for Social Prescribing and the World Health Organization. So you can see it in there. There's also a book that came out. I highly recommend you give that a read if you haven't already. It's called Social Prescribing Policy Research and Practice. So you'll see the outputs of the Delphi study throughout that book. This was a really interesting one as well. Some kind of unconventional uses I've seen. This includes an affidavit to the Canadian Human Rights Tribunal that uses the conceptual definition to argue for the importance of addressing the non-medical needs of First Nations children. So I thought that was really interesting. And I've also seen its use in presentations for sure. And then I've also seen efforts to kind of translate it and have it work in different countries and for different uses. And so this includes a Delphi study by the German Social Prescribing Competence Network, where German language terms were developed for core terminology and the definitions and framework. And what I want to do before I wrap up is just take a moment to provide an example of how the outputs of the Delphi study have been used in my own work and how I found it useful personally. And so as the final phase of my doctoral work, I conducted a scoping review to map the evidence on the use of social prescribing for children and youth. And I used the operational definition to develop the inclusion and exclusion criteria and to build the search strategy. And so by using that definition, I was not only able to find a relevant evidence source that was not labeled as social prescribing, but I was also able to rule out multiple evidence sources that were erroneously labeled as social prescribing. So it was a really great way for me to really just use that definition as sort of a way of measuring or assessing whether something qualified for the review, regardless of whether or not it used the label of social prescribing. And that made it really, really helpful. What I want to wrap up with here is my reference list. And I just want to say thank you so much for listening. And I wish you a wonderful rest of the conference and have a great rest of your day. Thank you.
Thank you so much, Caitlin. And you will join us after lunch because it's so early in Canada right now. And now the Hillevi Busch take over and talk about the mapping in social prescribing in Sweden.
Yes, thank you very much. And thank you for inviting me to this conference. My name is Hillevi Busch, and I am a PhD in psychology, working as a senior analyst at the Public Health Agency of Sweden. And I will talk today about social prescribing with a focus on loneliness. Next slide, please. And I would like to start by giving a glimpse of our Swedish strategy against loneliness because it is relevant for social prescribing. So the Swedish strategy is called Standing Together for Socially Connected Society. And the main goal of the strategy is equal opportunities for social relationships. The strategy has 3 different sub-goals, where the first goal is to promote social connectedness in the whole population. The second goal is about preventing loneliness in risk groups. And the third goal is most relevant for social prescribing because it is about identifying and helping people out of long-term loneliness. Next slide. And just a short background. The Swedish strategy was finalized about 1 year ago. And since then, the Public Health Agency of Sweden has a governmental assignment to implement the strategy in Sweden. And also to study how social prescribing is used in Sweden. And the design of our study was divided into 2 parts. So the first part is about an empirical study in the Swedish context. And then we also have a systematic literature review. And in this part, we have been supported by the SBU in Sweden, and that is the Swedish Agency for Health Technology Assessment and Assessment of Social Services. So, and this was a systematic review of systematic reviews. And also, this review was divided into 2 parts. So the first part is about how social prescribing is described in the literature and how it is carried out. So a descriptive study. The second part is about what are the effects of social prescribing when it comes to loneliness. Next slide. Yes, and the definition of social prescribing, we used actually the Muhl connection definition that we heard about, so I will not go into this one. We can take the next slide. Yes, and when it comes to the empirical study in Sweden, we had 3 different research questions. The first question is in what ways and in which context has social prescribing been used to reduce loneliness or to increase social connectedness? The second question is about what are the experiences of using social prescribing from the perspectives of prescribers, participants, link workers, and service providers. So we use the term participants instead of patients here. The third research question is what seems to work well with social prescribing and what needs further improvement, and also what barriers and opportunities exist. Next, please. Yes, and in the empirical studies, 11 initiatives were identified that fulfilled the criteria for being included, which were based on Muhl's definition. And we conducted 41 semi-structured interviews with 12 prescribers, 9 link workers, 9 service providers, and 11 participants. And those 11 initiatives that we found were from all parts of Sweden, from north to south. Next, please. Now, I will give you some of the results of the study, but remember, please, that some of them are just preliminary. So, We can see that social prescribing is carried out in very different ways, actually, and it concerns activities and target groups, but also the remittance procedure. And this was also a finding of the systematic review, the descriptive part of that review. And giving a few examples, when it comes to activities, we can see differences in how they are given. Sometimes they are, it is a fixed and closed program, only for participants that share the similar problem. In other cases, the activities are open for everyone, for the participant, but also people in the community. And when it comes to the target groups, there are differences, for example, in how people use criteria. For some social prescribing, there is an inclusion criteria, so you have to fulfill that to be included, while others do not have such a criteria. And we can also see the difference in the remittance procedure, where some use link workers and others do not. And in Sweden so far, we can see that social prescribing is usually used in a project form. And this means it has a start and an end. It has also a short-term funding. It is quite often dependent on enthusiast souls, which makes it kind of vulnerable also. And we can see that in most cases in Sweden, it is not yet a part of ordinary health care. Next slide. Yes, and we can see that there are positive experiences of using social prescribing, but there are also challenges. And almost everyone that we interviewed had positive experiences. We can see that participants are perceived as being happier, and participants also report increased self-esteem and self-confidence. However, there were kind of few participants in this study that had formed long-lasting social relationships. And when it comes to the systematic review, we can say that unfortunately, we couldn't actually evaluate the effects. And this was mainly due to a high risk of bias in the systematic reviews that were included in the systematic review of the systematic review. So this means we actually have to do a systematic review of the original studies. Okay, then another finding is that it is kind of hard to draw a conclusion of the long-term effects of social prescribing here in Sweden, at least. And that is mainly because the participants are rarely followed up in a longer term. And you can also see that the participants, the prescribers rarely got information about how or if the participant participated in the activity or not. Yes, and we can also see from the systematic review also, there is a difficulty because the interventions that are given, they differ very, very much. So it's very difficult to compare or evaluate effects. But social prescribing is perceived as a valuable complement in the healthcare sector.
1 minute.
Yes, thank you. Last slide, thank you. And what is the next step then? In the short run, we will report to the Swedish government the 1st of June 2026, and this will include our total work on loneliness during 2025. But social prescribing is an important part of this report, and we will have to balance also what does the science say and what is the proven experience. And finally, I can also tell you that this SBU report will soon be published, and they also highlight the need of high quality systematic review and also studies of cost effectiveness. Thank you.
Thank you so much, Hillevi. Then we give the picture, maybe the video, to Charlotte Osborn-Forde, Chief Executive of the National Academy of Social Prescribing in the UK.
Hello, everyone. Good morning. Just give me a moment to share my slides. Can you see those okay? Excellent. Such a pleasure to be here this morning and to hear already fantastic presentations and speeches from my fabulous colleagues. So I'm Charlotte. I'm the Chief Executive at the National Academy for Social Prescribing in the UK. I'm going to give you a summary of social prescribing in the UK and a little bit of how it's evolving around the world. And to say that the National Academy is also a WHO collaborating centre for social prescribing policy and development, and that was announced just last month. So we're just on our journey to doing that work. So in England, we are the registered charity funded by government to advance the study and practice of social prescribing. So we were founded back in 2019 by government when social prescribing became healthcare policy and was rolled out in England. And we have those 5 functions around connecting up the system, identifying and sharing innovation, driving investment and funding into social prescribing and community initiatives, championing, sharing the evidence, whether that is research or people's lived experience, and raising awareness. And we do that through a wide range of tools, resources, events, and knowledge sharing. So our website is the ideal place to find all of that. So social prescribing, as Sam has already told us, has been going on in England for some time, but the real key moment was back in 2019 when it became part of the National Health Service policy. And this statement is still on the NHS England website, that this is the biggest investment in social prescribing by any national health system. And this phrase, I think, is really important. It legitimizes non-medical community-based activities and support alongside medical treatment. So this shift wasn't just about finding a funding source to invest in social prescribing. It was about the health service recognizing that the community-based activities are as valued and important and legitimate part of healthcare. Now, this is a huge, ambitious and very positive statement. We can't necessarily say that the whole of the NHS has shifted and that community-based care is genuinely has that parity of esteem, but we have made some progress in England, and I'll tell you about that next. So I can see there's already been some questions in the chat about what is a link worker, and we have lots of information at the Academy in what link workers do and how they work, but this is a short summary. The diagram on the right is an official NHS England diagram, which shows how social prescribing was embedded. And you can see in the centre, the social prescribing link worker is core to social prescribing in England. And uniquely in the health service, they are employed to give time. So just as Sam said, this is not about what's the matter with the patient, it's about what matters to the patient. And the role of the link worker is not to diagnose or treat or solve problems. It is to empower the patient to understand what's important to them and then to connect them, as Caitlin has described, to activities and initiatives in the community. The model in England is national funding through the National Health Service down to GP, family doctor, medical practices for them to employ and cover the costs of employing a social prescribing link worker. Link workers are not medical staff, they're not qualified, but they should have a background in supporting people. So typically they will come from social care or health or community or charity and have worked with people who have issues and problems. They must be good listeners, empathetic, proactive, and they must be able to work in a complex system like healthcare and update medical records. Who can access social prescribing? All patients that are registered with a GP primary care doctor in England have a right to access social prescribing. It's part of the GP contract. What is a typical social prescription? It's incredibly varied. The national funding from government only funds the link workers. So the prescriptions are typically funded in a very wide range of ways through charity funding, local government, and there are over 170,000 different charities. So it's really depending on what the person wants and what's available in their area. Since this has been rolled out, it has been hugely successful. So as Sam said, we now have over 3,000 link workers employed in GP practices. There is no national data about other link workers employed through other health systems, through hospitals and through local authorities, but our estimates say it's about double. So we estimate around 8,000 link workers in total. We know that during the 5-year rollout, there were 9.5 million GP consultations involved social prescribing in some way, and 5.5 million referrals directly to link workers. We now have incredibly robust evidence, and I'll share some of those in my next slide. And around 23% of the public in England understand the term social prescribing, and 97% of GPs say they are favourable to it, which is a huge shift from 10 years ago. This is one of the most important pieces of research in England, which was published last year. It's a 5-year study. It looks at satisfaction rates of GPs, of family doctors in England, and it analysed national surveys of satisfaction rates and found a direct correlation between the number of social prescribing link workers and positive responses for patients feeling more able to manage their long-term condition and more satisfied with GPs. So it's a large-scale and very robust study that has been helpful in England to understand the benefit of social prescribing. And again, I've popped links into these slides, which will be sent out afterwards so that you can access this research. The Academy did its own study into health data. Sam mentioned the statistic of 23% of patients saw a reduction in A&E. This study looked at 9 examples in different healthcare systems of where social prescribing had reduced pressure on the NHS, either through doctor's appointments or hospital admissions. And it looks in detail at those examples. Some do have matched control. So they looked at a cohort who had experienced social prescribing and analysed their NHS usage, and a cohort that had not. And that cohort typically saw increases as their health worsened with A&E attendances and others. There was also a large government-funded study looking particularly at nature-based social prescribing. So social prescribing that is in outdoors in nature, such as walking groups, gardening, nature conservation, anything that involved a connection to nature. This was an £8 million investment, and it looked into 7 particular local areas, and an academic partnership produced an evaluation which was very robust. Some of the details are included there. So over 8,000 people engaged in the programme. We found 57% of participants were from the most deprived areas, and 21% were from ethnic minority populations that typically find it harder to access healthcare, and as Sam's presentation showed, more likely to have serious health conditions earlier and to die significantly earlier than more affluent populations. This programme measured using a score we call ONS4, which is a well-being measure looking at happiness, life satisfaction, anxiety, and life worthwhileness. And we saw significant improvements for people in those measures. Some of the sites particularly looked at more clinical measures for anxiety and saw important changes. And overall, the report stated that green social prescribing is as effective and as cost effective as other medical interventions for people with anxiety and depression, such as CBT, and that there was a high level of economic value into the programme. Alongside the medical research and other sorts of approaches, we have really focused on securing public awareness. And we've done that through encouraging the national media to talk about social prescribing. We have some amazing stories from people who have benefited, sharing what it means to them. And that has been in national press and sector press to try and raise awareness and build this case for increased and further investment in social prescribing. Sam happened to mention in his slides about the church, and a fairly new initiative that we've been leading at the Academy is to better connect up all of the provision provided by different faith communities into the NHS and the health service, recognising that they do so much for community well-being and often work in a very inclusive way, not about their own religion, but about improving communities. And we're just starting a piece of work to better embed faith communities in healthcare. Moving on in England, we now have a new national model for our health service and a new long-term plan for the health service, and that includes a commitment to neighbourhood health. And this is an official diagram from that plan. And you can see the outer circle. It is important to connect people out to wider support, public services, the third sector, which is what we call charities. So we see that as important for the continued growth of social prescribing in England. And we've already talked on the amazing work around the world. Social prescribing is growing rapidly. And at NASP, we are the secretariat for something called the International Social Prescribing Collaborative. This is a coming together of leaders around the world who wish to support social prescribing in their own institutions or countries. And we meet regularly to share updates and information. We also have an evidence collaborative and an evidence newsletter. So this will go out monthly, and it has all of the latest research and evidence which has been published on social prescribing. And we have our new collaborative focused on arts on prescription. I'll quickly talk about this slide, which I think is an amazing example. Many of you will have heard of Social Prescribing EU. It is a large, multi-million-pound, long-term, randomized control trial for social prescribing. This is really important because it will give us the robustness of evidence that is often missing, which was in the previous slide. We often don't have these large-scale, incredibly robust studies, and that's exactly what this project aims to do. It's in 11 countries. There are 20 partners involved, and we hope it will give us the research needed to make social prescribing care as usual. And we do have this report, which we produced with the World Health Organization last year, which summarizes social prescribing around the world. It's available on our website, so please do take a look. And lastly, there's all our information. If you're interested in anything that we have here, you should be able to find it on our website, and equally you can join up to our various mailing lists. I'm going to stop now because I think I have time for questions. Is that right, Paula?
That's correct. And thank you so much. And I have one, I don't know if that's for you, but I have a very interesting question about the link worker. If some people discuss if they should change to a digital hub instead of the personal link worker. What do you think about that?
That's a brilliant question. So the NHS, when they implemented the idea of link workers, considered this very carefully. And our link worker model was also born from a national government strategy for loneliness, just as we've heard in the previous presentation. And it was decided that it is the personalised care and the time and the relational support between the link worker and the person that leads to the outcome. And so all of the NHS guidance for social prescribing focuses on that relationship between the link worker and the person. And in fact, the digital side is hardly mentioned. And when I challenged this and asked about it, one of the advisors said, well, actually, with Google, that will tell you everything you need to know about what's in your local area. We don't need more information online. We need somebody to listen and take the time. And I think that's exactly right. That's not to say we don't have digital systems that can support link workers. We do, and some are excellent. But the heart has to be that relationship.
Thank you so much. It was a very clear answer to that question. And I think we're going to have that in mind. social prescribing is about people to people. And now it's time for our devil's advocate, Andreas Stromby, and he's going to talk about challenges and concerns about social prescribing. Welcome, Andreas.
Okay, so thank you for that introduction. Are there any challenges and concerns about social prescribing? Well, I guess we'll see when I'm finished and when we had this panel talk. It sounds really good, and it's been really interesting to listening to all these previous presentations from the experts, because I'm not an expert within the field of social prescribing. I'm a general practitioner working with patients, and I'm also a researcher and the president of the Swedish Association of General Practice. So to me, I totally agree, and it's obvious that loneliness is a major health threat. We see it every day in our clinic. It's about the youth, the elderly. It's in all age groups and different parts of the population. And of course, this is a consequence of how the society is organized. It depends on everything from the school system to work policy to community organization, social media, cultural aspects, and etc. And also several of our core values for general practice are related to social prescribing, actually. We should use the holistic perspective when we meet our patients, in which the social perspective is, of course, really central. We should work for equality in healthcare. We should offer person-centered medicine, and also acknowledge that social strain is a big part of the disease process. So how can this be anything to question? Well, I think that my major concern, or something that I want to discuss, is who should then work with these problems. Should loneliness and different parts of social prescribing be solved by healthcare? Are there any problems with putting this into the healthcare, because it might imply that this can be fixed by using a one-by-one approach to people when they already have symptoms or diseases, because that's when they come to me. That's when they are not feeling well or already have become sick in some kind of way. So the question is this effective, and is it perhaps too late? So if we take the systems perspective, we know that the primary healthcare systems globally and in Europe and in Sweden, we are really strained. We have too little resources in relation to what we are told to do. And the question then is, how do we manage this flood wave of recommendations that hits us almost every day? When we add social prescribing into the primary healthcare system as another task to do, other things will be displaced. And one argument, of course, which might be a really strong argument, depending on what all these research studies end up by showing, is that social prescribing will, of course, replace the need for other healthcare tasks. People will become healthier and thereby reduce their need of care. But do we really know this? Well, I think that the evidence is a bit scarce for now, but it's really great to see all these big studies that are going on. So what does actually the word prescription mean to me? Well, when I prescribe drugs, I do this because there might be safety concerns. I need to tell my patient that this is your prescription. You should take this number of pills each day with these with these doses and so on. And the question is, should social activities also be prescribed? Do we need to prescribe them in this kind of way? Is it the correct word to be used? I think Hans said something in the beginning that perhaps we should use something else than prescription. I don't know. And I also see that there might be some problems with medicalizing these actions that we take. If we, like an analog in Sweden would be the ADHD pandemic in Sweden, where really many kids have been getting these diagnoses just so that they can get the correct support in school. Whether the diagnosis or not is correct, it can be discussed in many cases. And I see that there might be risks with this in social prescribing as well. do we force the patients to go to the healthcare systems so that the society can help them with getting into a social network and getting this support? I don't know if that's really good. So I think we should talk more about that, and there might be some problems with this because sometimes the primary healthcare system is like this lifeboat. When you have a problem in society, you can always put it into the primary healthcare system and hope that they can solve it in some kind of way. And sometimes, of course, we should do this and try to do our best, but we must also know that when this lifeboat becomes full, someone else will have to swim on their own. So the question then is, do we know enough about social prescribing to make this broad implementation? Do we know that it's that there aren't any negative effects of putting these social problems into the healthcare? And if you want to read more about this, I think that this opinion paper in BMJ was really good by Margaret McCartney. She's coming to Jönköping actually to talk at our Nordic Congress rather soon. And she is taking this position that medicalizing a walk in the park might not be that good actually, which is a process going on in the UK, but I'm not an expert in that. And we also have this Swedish Agency for Health Technology Assessment and Assessment of Social Services, which actually tried to do this systematic review of evidence for social prescribing. And they concluded that there are few published studies on social prescribing for people over the age of 60. More well-designed long-term studies are needed before the intervention can be implemented more broadly. And there is a lack of knowledge about the effect of a so-called link worker. So I think that we should keep on doing this research, which have been described, and I think we should be careful about what we put into the primary healthcare system as a new task to work with, and what should be done by other parts of the society. Thank you.
Thank you so much to lift these concerns of yours, and I think it's so good to have it up to the table. And we have a roundtable discussion now that we will discuss these issues with the other speakers we have heard today. And about the prescription term, I think Sam also mentioned it in the beginning. It's because we want to that they wanted to have the ear from the primary care and from the doctors. That's why to say that this is a prescription that has effects. But I now give the word to Susanna and Hans, I think, as moderators of the roundtable discussion.
Yes,
and
thank you. Thank you so much, Paula. Thank you so much, all speakers. Sean, you wrote something in the chat here as a response to Andreas' question about the concept. Is it a good name for it, social prescribing, or not?
Yes, so in England, I'm Sian Brand. I'm chair of the Social Prescribing Network. The network was created over 10 years ago now by Marie Polly and Michael Dixon in the UK. We have a global membership, and we supported NHS England set up the modelling for social prescribing as a collaborative effort. This was just as NASP was forming, so in very early days before it had become national policy. And all across the country, we and ahed for considerable times as to the term social prescribing. But as the funding was coming in our country from NHS England and we were trying to engage through a primary care focus model, it was felt to create more of an impetus around this significant shift in approach from pathogenic medical model to sitting alongside the salutogenic prevention. We needed something that they could align to and buy into. Yes, I agree, it's come with the risks of medicalizing social prescribing, and we're working with those risks. We work with them every day, but to try and mitigate that, we included within our modelling that the link worker role could be hosted by a voluntary sector organisation and could be placed actually within the community. There are tensions in some places as to GP practices thinking it's their link worker and not part of a bigger community. So if you look at social prescribing as a whole, there are two elements. We have the intervention that it's turned into with the role and the prescriptions. And then we have the architecture. And whenever I've worked as a consultant in areas, I work with people collaborative across a whole community, engaging them in their role in social prescribing. And when I teach on our level 3 qualification in the UK, I say social prescribing is everybody's business. So pre-NHS, I also worked with schemes of social prescribing that were funded and hosted by local authorities and public health, and also some that were completely delivered and funded and also had lots of volunteers in the voluntary sector. So there's lots of sorts of modelling. In terms of the referral piece, I think you're right. There is a risk of us over medicalising, over complicating what is natural to being a human. And I think that's a challenge that we're working on. Unfortunately for us, because our model is, rooted in primary care, that does come with difficulties, but it's all surmountable. It's how we work with communities. Thank you, Hans.
Thank you, Sian. Charlotte.
Hi, everyone. I really enjoyed your presentation, Andreas, because I'm very used to hearing these sorts of arguments. And you're right, they come both from practicing GPs, but also more sort of academic research papers. And all I would say is that's why that statistic I shared from a national survey of GPs saying that 97% are now favourable is so surprising. Because I met many GPs back when it became policy, and suddenly they were all told to embed social prescribing and recruit link workers, and many were deeply skeptical for all of the reasons you've described, saying, oh, it sounds like extra work, it might be short term, it's outside of what I normally do. And we could sort of talk to them endlessly about the guidance and the evidence and all of this. What always made the difference was one of their own patients who was particularly complex, had deep-rooted problems, and that they would see every couple of weeks and never feel that a difference was being made. And then they would refer to their link worker, sometimes from desperation. They didn't know what else to do with the patient. And then they would see that with some time, often a number of home visits and months of working, a real genuine transformation. And that patient coming back into the consulting room and saying, I'm actually feeling better. And they then turn into sort of advocates or champions. So almost every conference I do with GPs, somebody will stand up and say, yes, I was very skeptical, but now I'm a real advocate and champion. So I think it is the personal experience of the model. I also think in England, our model was, and has been criticised as such, it was really funded with the purposes of reducing pressure on GPs, because that image of the primary care as the lifeboat, it couldn't be more relevant here in England, where GP practices are under just incredible pressure because we have a completely free access, universal healthcare in England. And the GPs are the first point of call for very many things. And so the model was designed to provide extra capacity, not to be an additional task. And that was this vision of a link worker who will be within your practice and who you can refer these patients to whenever you feel this is, that the GP doesn't have time. And the link worker, that statement is they're employed to have the time. And that's something that it was really embedded throughout with the model, and is now criticised because some will say, well, actually, if we're assessing the value of social prescribing based on whether it saves GPs time, which we often are, what about the broader benefits to the person and to the community and those sides? So there's probably no perfect model, but the model that we designed and embedded in England has shown that it works well with GPs and, of course, with patients.
Well, thank you for that comment and clarification. So we actually had our doctors meeting this morning in my healthcare center, and we talked about this, not related to the meeting today, but just that, okay, so this patient really needs other things than what we can offer. So I get that, and I agree with you, Charlotte, that would be a really good tool to be able to use. The question is how do we talk about it, and how do we integrate it? I think, but it's really interesting to hear, and I look forward to following these new research projects that you presented previously. So.
Yes, how do we introduce link workers in Sweden? Susanna, you did a link worker project, or you did together with many other people in Högsby, where we had our previous conference in 2024 October. We had a hybrid conference then on social prescribing, the first in Sweden. Could you say something about that, Susanna?
Yes,
about the Swedish link worker model?
Yes, it was a link work or a social prescribing project, and it was a project that exactly as you pointed out, Hillevi, it's the how it is in Sweden. We were really trying to make this project work, and it is connected to all sorts of challenges, and we had the possibility to recruit this perfect person for the task. She had been working with people far from working, so really people who are not able to take care of their life situations. She had this experience from before, and she was employed by the municipality, and after some time and different challenges in the project, and according to the reality, she was ended up working in the healthcare center, and then we got connected, the doctors and nurses and the link worker for the hälsolots. They started to work together, and she could motivate people who had previously been booked for counseling with a counselor or with a doctor, and they didn't show up, and she worked with their motivation and helped people feel safe enough to actually show up in the healthcare center. And she and the counselor and the doctors and nurses, we were able to help people out of very difficult life situations. And this was a pilot project, and so many challenges to get it to work, and we stumbled on the financing in the end. So this project died. It's on the project cemetery, as many other good things. And now when I work here on Gotland, I work together with a social educator, and she's fantastic. She does really wonders with people who are stuck in all kinds of problems. And we have a very strong focus now, much stronger focus now, and in the doctor group and nurses group, we need to be very focused on the medical assessment and do things with medical methods when there is a medical cause of the illness, and we need to not to do these things when the main cause of why the person is not feeling good is something else. Then we need to connect to the local resources within the local community, and we have many resources, but no one to sort of coordinate what is here and now in Slite community on Gotland. What is here and now? It's not good enough to post things on a website, because then half a year later it is old data, and it's also really important with the person, that is as a real human person who takes over and helps the patient solve problems. I heard this morning with our social educator, she had been helping a really obese man to clean his apartment, and now it was so messy that he couldn't see how he could get a better grip on his life, and now he's much more on top of things, and he can manage his life in his apartment, and he cleans, and he sort of shows interest in cooking now, and he can join this group that Grown-up Education Association is giving here. So it needs to sort of grow both from inside the healthcare, and we need to focus on knowing the person, so person-centered care, and then not do medical things with the 80% causes that are not medical. So when we are closely linked to resources, it's much easier to do a good job as a doctor. Yeah.
Thank you, Susanna. There's come up a question. So should we have social workers employed instead of link workers at healthcare centers? One question in the chat. And another question is the link worker, you've heard the expression, the doctor drug coined by Michael Balint in the 1950s. The doctor acts as a drug, and it's him or herself. So is it the link worker drug we are looking at as well? Sean, Charlotte, or...
I can answer that. So in the UK, we have, you may have heard of Professor Daisy Fancourt. She's at the University College London. She's a real global expert on social prescribing research. And we did a seminar together last week, and she had exactly that question. Is the intervention which is leading to these outcomes, is it the link worker, or is it the intervention itself? And how can you understand which part? Because a lot of her work looks at the detail with, say, a creative intervention. Is it the creative expression? Is it the social contact which leads to the outcomes? And she explained it better than I can, but she said it is often both. And it's very difficult to tell because of the individual's nature. But when you actually map the different outcomes, the link worker on their own often is the intervention, because just being listened to and valued and being able to talk through what matters to you. So the approach a link worker will use is they will ask those well-being questions. How happy have you been recently? How worthwhile is your life? How satisfied are you with your life? And people having the time to sit back and reflect on those questions, that's inherently, in a way, therapeutic. And that's what a good link worker should have the time to do. And then, of course, the actual activity, whether it is swimming or gardening or art or just a coffee morning, brings its own benefits. So it is possible to sort of dissect those different parts. But overall, the research we have at the moment is telling us that it's very much both, and that both parts should be valued. And just going back to the point about where the sort of the doctor or the GP sits in this, and I think in other countries where perhaps there is less of an urgent pragmatic need to embed social prescribing than in England, where we do have this incredible pressure, doctors and nurses are more involved in the actual practice and process. So one example would be in Catalonia in Spain, where social prescribing is being embedded, and they don't necessarily have specialist link workers, but they have a medical record system that enables various members of the medical team, some GPs, some nurses, some other less clinical but typical primary care roles, to make those referrals and have those conversations, and they're all trained in how to do that. So there are slightly different models, but our model in the UK, I would say, is very much a sort of a pragmatic response in some ways to the issues that we have in primary care and the issues that we have in wider society around, as Sam said, huge inequalities and many people really struggling with health problems, with obesity, with other conditions, which are not sort of solvable by the traditional medical model.
Thank you. Andreas, or was it Sean, or?
Well, I don't know if Sean was before me or.
Yeah, it's just a very quick response about the social care bit. I've dropped it in the chat, but in the UK, both the social care profession and occupational health both had very key elements of the link worker role within their professions many, many years ago. And it was fundamental to how they worked with people in those professions. What's happened over the previous decades is as statutory services have been more and more pressured, and thresholds to access those services have risen, they're now seeing only the most vulnerable, the most complex, the most in need. So they're going further away from, that salutogenic approach of prevention, which has then left this massive gap of prevention and the need to stop things happening much earlier and people connecting to their communities. So that's where the link worker role has filled in. So we have had pushback from those professions saying, well, that's what we do, but we don't have time to. You're taking our roles. Actually, there's more than enough work for all of us to get on and support people in prevention. It's just working out who and where can do what and when in the best way. So we utilise our resources and our capacities and skills as a whole, as a collective, and that will look slightly different both across England but also across Europe and globally, because we have different cultures, different systems, but it's that asset-based approach of utilising those skills and not so much being precious about what we're doing, but actually we're all serving the same people. Whether it's a policeman, an ambulance, a librarian, a voluntary sector worker, a volunteer, a church worker, a doctor. It's the same person that we're seeing. We should be thinking about putting that person at the centre, which is the essence of social prescribing.
Thank you, Sean. Andreas.
So I was thinking about these discussions about what is actually causing these positive effects. Then is it the link worker, or is it the activity, or both, or so? And because if it is the link worker, which perhaps would be to me a rather not that strange if it would be so. It could be the link worker which brings a lot of these effects. Then we will have a capacity problem because we have thousands of people needing to see link workers. It's like I prescribe a friend. So that was one thing that I was thinking about, and I guess that we will need to find out where these projects have these ripple effects. If we start by doing this in the society, does it start to become more like socially active in other circumstances as well? Do we see that our inhabitants in the society goes into these activities by other routes than just by the link worker and so on? So that's really important, I think, for us to be able to offer this to all the people in need. And I don't know really if you have seen any of those effects in your research or studying.
Sean, you
Yeah,
respond?
so I think there needs to be more research about the role of the link worker and the role that they play. We've focused very much on it as an intervention and the numbers and the health and wellbeing outcomes, but I think there's something really quite magical about having a transformative coaching conversation. If you have a link worker that just signposts, anybody can signpost. We could all be connecting. But it's that, as Charlotte has said, the spending time with someone, building trust and rapport, and having those transformational coaching conversations. So you shift the dependency to be able to self-serve, self-care and self-manage in communities. So yes, Andreas, you're absolutely right. There's a massive capacity issue around that. But if we work in a proactive social prescribing way where we're focusing at those that are least activated and motivated to change and have the most issues in terms of their health, well-being and social status, then actually they're the ones that are costing the system more in terms of time and resource, and also not fulfilling, having a fruitful life, a joyful life. So spending time with those first, I think, is more important. Then the activated and motivated, generally by the nature of how we work in social prescribing, they'll need less time anyway. So if I'd suddenly been bereaved and ended up seeing my GP with anxiety and depression, I'm quite an activated, motivated person. So maybe half an hour conversation is enough for me because I get it, I know things, I'm signposted, I move on. But the other time with the most complex is where the magic is, I think. But yeah, I completely get that capacity issue.
Thank you so much, Sean. Now, Susanna, Anita, but we have lunchtime now, but maybe Susanna and Anita, then we'll end the discussion and take lunch, okay? Susanna first.
No, Anita was first.
Okay, Anita was first, sorry.
Sorry, I just wanted to sort of say very quickly, we do have studies that are showing that it's actually also the group, because we do group-based activities, and the social connectedness in the group is very important. But it's also the link worker and the facilitator of the activities. So it's all the sort of human interaction that actually contributes to the well-being. And also it's important that there is a continued activity afterwards. We prescribe 10 weeks. What are the patients to do after that? There needs to be something like that. But I think it's all the social connections and community that's involved in the activities that's important.
Thank you so much, Anita. Susanna, will you end this before lunch? We meet again at 1 o'clock Central European time, noon UK time.
Yes. Well, thank you. I think we could
thank you, everyone.
Everybody about these things for like hours and hours. And yeah, we will meet again after lunch. I have like 10 things I could say now, but I will keep quiet so you get lunch.
Yeah, there's questions in the chat about what is the program after the break. I think if you go to the link to the sls.se, or you can find the program there. But otherwise, we will be looking forward to Christian Althenius at 1 o'clock Central European time. We'll talk about social collaboration, Swedish, European, and global perspectives. And then there will be people from Norway, UK, Italy, Austria. So welcome at 1 o'clock. Okay, yes. Thank you so much for now. It's 1 o'clock. So Christian,
can I start showing here, or should I wait to the main
now? Group? Yes, yes.
I can share it now.
Yes, be welcome.
Perfect.
So please begin, Christian.
Okay, I can kick it off. Perfect.
Yeah.
I'm Christian Althenius. I'm part of the Swedish network Stop Involuntary Loneliness. And today I'm going to talk about social health collaboration and networking, or rather, I would like to put it about reaching out, because that's what it's all about. Reaching out to the person that we want to help, reaching out to us to collaborate with, reaching out through link workers, a term that we have heard and that I love and that I will stress also in this presentation. But I would first like to start with something that most of you probably have heard of, the EASE model. So it's a model developed by John Cacioppo of the US quite a while ago, and in order to guide someone that had been far away from a social context into a social context, or even guide yourself. But if you look at it, if you look at the first step, extend yourself, put yourself in a social context, initiate contact, say hello, engage in small talk, that can be actually quite scary for our target groups, people who are actually into social describing, that we're helping with social describing. So in this context, I would like to add another step, a new step to the EASE model, and making it the PEACE model, prepare and practice. Because many of the people that we meet, they are not anywhere close of being ready to put themselves in a social context, even say hello. So it's like we need to prepare better. maybe some of the initiatives that I see around social connection, they're a little too aggressive and sometimes a bit too ambitious. We have to take baby steps and go easy on these model. So basically, prepare and practice, like a main first step. Prepare and practice with the link worker, if you have one. And also, a good place to start is by finding a friendly online environment. And I've seen in the chat, digital context, online context have taken a lot of toll. But I think we should not shy away from the possibilities that there are in the online communities, because there are loads and loads of friendly social contexts out there, like Facebook groups and other hideouts and online platforms where people are trying to find new friends. There are a lot of people who are moving to a city or of some kind of reason have been far away from social context. They need to come back. So there are loads and loads of Facebook groups to be found. And I think that, okay, some of them, they are not very friendly. They can be quite harsh language. But one role of us working here, and especially now the link workers, can actually be to try and identify and find these first steps into social context. So find a friendly context where people are helping each other, collecting courage enough to actually come back to a social context. And it's all over the place. So if you go searching for like new friends, neue Freunde, and depending on what language you use, you will find groups to explore. So that's an excellent first step. And someone who has definitely explored the digital and online possibilities is an innovative municipality in Sweden, Mariestads kommun. They are actually right now in the process of hiring a game changer. I think it's so brilliant because I've understood that where are the people that do not come to school anymore? Where are the people where are they to be found? Those that we often talk about are the most hard to reach and put into a social context. Well, of course, they are in their homes. And what are they doing in their homes? Well, most of the time, actually gaming by their computers. So here we have a municipality that have decided to hire a game changer, or I quote, a bridge builder between social isolation and community. You meet housebound people, absentees from school, where they are, often in the digital world, and use computer games as a tool to build trust and open doors to support new opportunities. Through outreach work and relationship building efforts, you help individuals to break social isolation and find their way back to community and sport. And it makes me really warm at heart because I understand exactly what it's all about. Of course, it is about bringing people back to a social context, but where are they to be found? By their computers. So we start by actually, finding them where they are. Excellent work. I'm going to stay a little bit longer in the digital world, actually, because as I said, social platforms and social media has often been, taking a great deal of toll and being antisocial. But now we are seeing that there are actually real social platforms and apps appearing. That is, apps that want to bring people, like acting as a springboard into a real social context. Many of you, of course, know Meetup. It's been around for quite a while, so it's nothing new. But what we are seeing now is that they may be more narrow. We have social apps that are more like going for interest and so forth. And also for certain interest groups. We have, for instance, in seniors, the Union for Seniors, so to speak. They made an app by themselves, Mötesglädje, a social app for and developed by seniors. Excellent way to do it. I see a new site called Pop By, which I'm following with great interest because they are really, trying to solve this problem. Okay, how can we actually reach people who aren't finding us themselves? We are seeing apps like Olio, food sharing revolution, and that's economic, and environmental and social sustainability in one. Because you don't only share food, you actually share your meals. So there's a lot of apps popping up. So the link workers should really pay attention to these. What is there actually out there that could help us in our work and could help the people that we are helping finding a social context? Because again, bottom line, agree completely. The heart in social prescribing is, of course, the real contact, real relationships. But the way to it is through the online possibilities. And reaching out. Well, again, we often say that it's very hard to reach out to many of the target group. Well, again, we know where they are. They are mostly at home. So, and who are best to find them, so to speak, and to help out? Well, of course, it's like the family and friends. There's a really great word for it in Swedish, anhörig, which is not only family or relatives. It's like it could be close friends or family of choice. And if you're curious on those kind of initiatives, you should check out NKA, the Swedish National Competence Center for Relatives. They are providing a huge amount of networks, basically engaging relatives in different contexts. And loneliness is one of these areas. I also see Attention, the Swedish Nationalization for people with NEDs like ADHD and autism. They are also using the digital challenge to reach out to the people that they cannot reach. And a fantastic way to reach. And I tried it out yesterday. They have over 1,000 members of the group, and there were actually 30 people socializing online on their Discord channel yesterday. Now, how and where to engage? Well, I think there are, of course, lots of organizations that are sort of touching social health and volunteer centers, charities, organizations that are excellent places to work with and to cooperate with. Because like if you engage, if you help someone into a charity, you get like a win-win-win. You place someone in a social context, you get the feeling of being needed, and also on top of that, the joy of making a difference. And of course, there are lots of organizations like that across the world that are perfect to engage with when it comes to social prescribing. And I was a bit hesitant to show this picture because I was starting to map sort of the collaboration around social health and social prescribing, because it's a jungle out there. There are loads of organizations and networks, and it can be hard to, figure out, okay, where to go, where to start. And I think if you're new in this business, and I think that it's just to start somewhere on your local context, because luckily it's all intertwined. We have NASP that we saw before. They have tremendous, fantastic work, and also mapping the social prescribing around the world. We have the Social Prescribing Day coming up in March. We have the WIS. We have initiatives in French, Fédération Française de Liens Sociaux. We have GILC addressing loneliness and connection, etc., etc. So we are all sort of intertwined. But if you want to have one place, I would like to recommend the Social Connection Collective. And this is especially if you're into social health and the loneliness aspect of it. This was a grassroots initiative initiated after the WHO launch of the Commission on Social Connection. And it's like a first step for professionals getting to know each other, building on each other's experience in social health. So if you want to reach out to find more people to collaborate with, this is your place to go. And again, we often say that the hello is like a magic word that will open up a lot of doors. And it's about, I think, about creating reasons to say hello, about getting like people a reason to socially engage. And the World Hello Day is a perfect day to do so. It's actually a growing international movement. When we picked it up like 2 years ago, it's been around since 1973. It's a bit sleepy now, but we picked it up. Australia's coming on, and we are having a complete World Hello Week in November this year. So we really hope that more will join us then. So basically, key takeaways from this piece. Well, again, go easy on ease. Adding a P to this model makes it socializing easier. Don't shy away from the online platforms. Yes, it's all about the real connection, but try to find the online platforms as a way to step into real connection. Collaborating and leveraging from each other's networks, well, cutting corners and time. Use the power of reaching out to your target group through friends and family. Explore the role of the link workers, maybe the most important link in the social prescribing chain. And again, everything starts with a hello. So join the World Hello Day movement. And that would be all from me, cramming 45 minutes into 15. Sorry for speaking so fast. If you want to reach out to me, please connect with me on LinkedIn.
Great, Christian. Thank you so much. Paula, do we have time for some questions maybe? Because we haven't reached the 1:15 yet.
Yeah, there's 2 more minutes for question. I haven't seen one in the chat, but one short question.
Yeah.
If anyone.
What is the question in the chat?
I haven't seen any in the chat.
Oh, you haven't seen? Okay,
no,
sorry.
No.
I thought you said you see some question. No, okay. Yeah. I was wondering, I was going to ask you, Christian, how come you personally got interested in this field? What's your personal background?
I'd say lived experience. I was moving from one city to the other, and I felt it was really hard to make friends as an adult. And this was before the time of Facebook or anything else. So I decided to start a website called citypolarna.se in Swedish. And so yeah, this is actually exactly 20 years ago. So I've been in the business of like exploring this field of loneliness for 20 years.
Wow, thank you. Exciting.
So yes, but now it's time for the next speaker.
Yep.
And it's Tobbe Sudman from Norway. And you will give us some examples from the Norwegian social prescribing. The table is yours.
Thank you. Can you see my presentation?
Yes, we can.
Yes,
it's great. Yep.
I'm going to give you a few examples from Norway, of the big pizza nation, but I don't eat pizza. I just have to confess that at once. My point of departure is health-related social need with underserved populations, and I'm drawing on personal experience, both as a clinician and as a researcher and as a volunteer. And my head and heart is into underserved population, hard-to-reach population, stigmatized population, and people who use substances, people in prison, re-entrants, those who are finished doing time, and people in long-term mental health care, and people who are unstable housed or homeless, or home dwellers with cognitive decline. These are the people I've met and who I've been lucky enough to work together with. And these underserved population, as we all know, I just have to remind you, they have a lot of living year lost, they have a lot of healthy year lost, and they have disproportional incidence of non-communicable diseases, whether that is cancer or diabetes or heart conditions. There are lots of multimorbidity, they have a lot of oral health problems, and low rates of participation in screening program, vaccination programs, and most commonly also low health literacy and low digital literacy, and poor nutritional status. And many of them also, as we know, have reduced access to public space, reduced social participation, and they meet a lot of barriers to access healthcare and social services. And they have consequently reduced access to civic engagement and reduced possibility of exercising their citizenship. So I work on farms, a social farm, and I want just show you what a farm can offer, whether you call this social prescription or not. It's a rich environment. It's a new arena with new possibilities for everyone who enters, and new possibilities to present oneself as someone else, just as they can do online in gaming. You can also do that at a farm. You can take new risks. You can experience agency, creativity, courage, and bravery. And you have the freedom to fail, first attempt in learning. And we know, as at least those of us participating here who are healthcare or have health science background, that it's possible to rewrite biological script by actually playing with the biological plasticity. We also offer possibilities for re-entrance into society, and we hope that people can make new friends, they can have new leisure activities, and they have new arenas of volunteering. And this is also what I have seen happening over the 20 years I've been trying to stay most of my time at farms, even though I'm employed at a university. And people have the possibility for new occupations. I do horses more than other animals. That's because they necessitate that you are present. Horses don't wait, and we have to go where horses live. So we leave arenas where things are difficult into another arena where there are new possibilities. And horses demand your unwavering attention, as do these small chickens. They also demand a different interaction order. So you have to respond and communicate in different ways, by hands, by breathing, by just standing or just being there. So if you're afraid of talking, you don't have to talk. And it also offers an enormous amount of variability in weather and ground surface temperature, ride, sound, smells, weather, and everything. And a lot of people, and horsey and non-horsey, and a lot of animals. I just want to pop into Italy. There was some Italian here. This is from Trieste. Because the revolution in mental health care was by Franco Basaglia, who tore down all the walls around his hospital and said that freedom is the way to liberty. And his favorite model was a horse. So he is also, of course, my favorite physician to say why we need to do horses. And his horses were always blue. And the inspiration from horses, they came from the Lipizzaner horse. Everyone's seen these beautiful white horses in all these shows on the television, which come from Slovenia, which is just a few yards away from Trieste. And horses, they enjoy freedom. They need their friends, and they need food and care, and then they take care of each other. And this way of living and enjoying life in a herd is what we also try to do with people. We need interaction and sociality. We need a herd. We need friends. And we need to acknowledge that our interdependency, so we can help and be of assistance to each other. And following from that, I view health as a social practice and a collective resources. Many of the speakers before me also stressed that all hospitals can only count for approximately 20% of our health, and the remaining 80% is social practice and collective resources which could be shared. So social farming in Norway is daycare, it's shelter work, it's regular work for people receiving disability benefits, it's community centers. There are maids and farmhands, there are volunteers, and there are staff, and everyone meet up and enjoy the day together. This is a quote for one of my patients. I met her the other day. She just went public with her story about several suicide attempts, but she's still alive. And she said 2 days ago, why didn't they offer me animals before medication? And social prescribing, as we have been talking about today, is other ways of relating to both social and medical needs by other means than medication.
Wow, that was a powerful quote.
It is. She told me 2 days ago. I almost started crying. But she's still alive, and she said that the horses saved her life. Because with horses, you can dare, you can try to push borders, you can try to breathe, and you can try to survive. And she also, I had this agreement with her many years ago that please stay alive just another week so you can greet your favorite horse once more before you jump off that bridge. And she was laughing about it 2 days ago, but she didn't laugh then. But she's alive. She's alive. And many of our participants and patients and all these different projects and activities I have run, they always come up with this is the best day of the week. Going to the farm keeps people in substance use treatment. Going to the farm keeps people alive. Going to the farms preserves hope. And that's what is important. These sheep are going to the slaughter, so the picture is not quite up to speed for the content of this seminar, but still, we need to make every encounter matter. And as several others have said, we have to ask what matters to you so we can offer support. But we also need to challenge people, not just caress them, but also challenge. We need to, in my experience, you also need to kind of provoke. You need some kind of movement to be able to instigate change. If we only caress and wrap in, there is no change. So we have to do something so change is possible. And we have to celebrate. And we have to support literacy, both when it comes to health, food, social literacy, and not at least also the cognitive literacy, particularly with these underserved populations which struggle with all of this. And farm life prompts for us. It's easy to ask, it's easy to listen, and it's also easy to follow up. So what we can offer in our arena, which is not a health arena, it's not a social care arena, it's a farm, a social farm. We can re-imprint biology by amending and adding. We offer a lot of possibilities for sensing. We offer also a lot of abilities for feeling different things. As one of my riders once said, Tuba, this is strange, I can actually feel something. Which was one of the prisoners. And we can relieve allostatic pressure by enlarging capacity for adjustments. And everything is done by daring and learning and having fun together. Whether indoor or outdoor. Come rain, come shine, there is no weather that can't give any possibilities for coming together. And this for all the Swedes, we actually had a daring competition by going by horse to IKEA. So these are just some of the horses, and we were standing outside. We were riding with prisoners and only men in substance use treatment, and I gave them my credit card and go buy whatever you like. And they came back with coffee and unedible sausages, but that is the IKEA food. But it was really fun. Okay, the last comment before I draw in is that if we're going to use the farm or the outdoors or animals, we have to remember that the welfare of those are the welfare of the humans, and we have to take care of and acknowledge this intertwined relationship between humans and our welfare and the welfare of the planet and the animals. This is from the Lancet. It's a really nice report for those who are interested. So, okay, I still have few minutes left. Take home. They came for the horses because everyone came to me because of the horses, but stay for what? A lot of people who have vested interests here, so they come for different reasons, but they stay and because also they experience the pleasure and the value of becoming thirsty, hungry, cold, wet, dirty, and tired together with other people. And we do also see that we can affect bodies, both inside, outside, literally, and also as a metaphor. And we also talk about freedom as a blue horse, which is what we offer. And what I do as a therapist, as a volunteer, or as a researcher is drawing on what is applied drama with devising, trying to co-create ways of having fun, taking care of animals, and enjoying time together with the animals. So as you have seen, we also have costume parties. And then I have to just, since the subtitle of this seminar was Projects, Arts and Prescription, and Charlotte just mentioned the book, the last book for Denny van Coort, so I just have to show you the picture. And she says that alongside diet, sleep, exercise, and nature, the arts should be considered the fifth pillar of health. And at my farm, at least on the social farms in Norway, we actually provide 4 of the 5 pillars of health. We always include healthy meals and talk about preparing meals or prepare meals together. There's always a lot of movement. We don't call it exercise, but being around horses in a stable is exercise. There's always nature, and there is art in the way of applied drama, improvisation, theater, sports, or singing or dance. And then thank you for your attention. I just remind you the photographs are taken with consents and the rest are the staff. And this one, again, it was just shown. I just wanted to show it one more. Thank you.
Wonderful, Toba. So great presentation.
Yeah. Thank you so much. And we have 3 minutes left. If anyone has a question for Toba. I think it's so great to have this various example of what social prescribing can be. And you showed this by animal, and the next speaker will talk about the green space as a social prescription activity.
Which was also part of my farm, of course.
Yes, of course.
A farm without nature and the green.
Yeah, absolutely.
Yeah.
Yeah.
Anyone? Yeah,
yes, I can. If you want to ask questions, the attendees, please post them either in the questions and answers section. Easier to respond to them there. We didn't tell you that from the beginning, or in the chat. I cannot trace any fresh questions in the chat, but please don't be shy. Write in the chat or in the questions and answers, and we will try to respond, or Toba will try to respond in the 2 minutes she has left.
Yeah. Did you have in Sweden? We talk much about the allergy. Did you have these questions that oh, I can't come because my mother is allergic to horses and so on? Is that a question, or is it a non-question in a way?
Of course, it is a question, but I'm working outdoor. I do have a riding arena indoor as well, but we work outdoors, so the allergy problem is much less. But I actually had one patient, and she was hyper allergic, so that didn't pan out. Otherwise, people have just taken an antihistamine or something, or just washed their hand or washed their face, and just be careful with not taking your hands directly from the horse's back to your face. So that hasn't been a problem. I'm allergic myself. I'm allergic to dogs and horses. But I just try not to rub my face with dirty hands, and then it's okay. And every now and then I take a blue pill, and then it's solved. Pragmatic.
That's good. Yeah.
Good. Joyce, you wrote something in the chat here.
Just to say that for the social prescribing and community orientation, we've got a member that runs a social farm, and he's thinking about how we can actually link people up to each other in the future to take different initiatives forward.
Yeah, that's great.
Great idea.
That's all social prescribing.
Sorry, Toba, are you engaged with people? I mean, are you engaging with people doing social farming in the UK or?
Not very much, but I have connections with Sweden, of course, with the Organisation för hästar and also during all these international networks as researchers, there's a lot of international networks, including UK. The research part of me is very much international.
Great. Now the time is for the next speaker. That's Joyce Cankry. That's good overgone to the green space for cancer survivors. Welcome, Joyce.
Thank you. So I'm actually the chair of the special interest group for social prescribing and community orientation within the World Organization of Colleges and Academies for General Practitioners. And we've actually been working together, and Charlotte actually mentioned a project run by a member of the group, a randomized controlled trial, Social Prescribing EU. And we put 3 bids in together to the European Union and actually got all 3. So we're really happy with that. And also the idea of taking forward research. So this space project, Social Prescribing and Civic Engagement, is funded by the Erasmus Plus programme. And it's looking at the idea of green spaces for cancer survivors. And it's looking at it in a way from a different perspective, because the lead organisation for the application was actually the Centre for European Volunteering. So Centre for European Volunteering represents over 50 volunteer organisations across Europe. And also the majority of the partners were actually from volunteer organisations. So Volunteering Ireland, Conservation Group in the UK, Cancer Federation in Greece, Rehabilitation in Europe, and Malta. So it's thinking, the different partners that we can actually work with in the future. So the project objectives was to build capabilities and capacity in health and voluntary sectors to offer social prescribing in urban gardens, based on research and observations. Social prescribing can be a useful tool in a holistic approach to rehabilitation, especially thinking about recovering from cancer. So it's thinking about, for the project, it was about co-producing with interested stakeholders a suitable approach, raising the capacity and confidence of health and social care and rehabilitation professionals, and also increase interest and awareness of the value of volunteering as part of social prescribing schemes. So for the project, we were looking at starting off by doing desk research, looking at the knowledge and review of papers across Europe, thinking about green spaces and cancer patients. And then we conducted focus groups across Europe with stakeholders, and then ran a European-wide survey. And what is happening now is they're developing a training package of materials, and then they're going to actually test that out in practice with rehabilitation practitioners, volunteer managers, and also health and social care personnel. And it's really trying to see, well, can we actually set a quality training program in place that actually helps with the implementation of social prescribing. So then there's going to be some rollout events as part of the program. So it's thinking about initially is looking at the literature across Europe and thinking about the social prescribing in volunteers. So first of all, scoping the literature, organising the focus groups, a survey of European practitioners, and then in a very short time, we had to create a state-of-the-art report to be submitted to the European Union. So the scoping review, we actually looked at citations of over 122,000 publications and shortlisted 60 studies, and then actually included 32 interventions. And the key findings from that was for gardening, improved physical activity and nutrition, nature-based activities enhanced mental health and mindfulness, physical activity, Nordic walking and community exercise programs, creative interventions, art and expressive writing for emotional processing, peer support, reduced isolation and improved coping skills, and yoga, holistic benefits for physical and emotional well-being. So the outcome of the scoping review, the initial scoping review of the literature, was thinking about the strength, positive impacts, psychological well-being, social connectedness, coping mechanisms, and also promoting physical health and healthier habits. And the recommendations that came out of that was to develop standardised protocols for interventions, provide competency-based training tailored to cancer patients, and also to emphasise cultural competence and ethical practice. There was quite a few focus groups run not only pan-Europe, but also thinking about within the different countries of the partner organisations. So within the UK, within Malta, within Greece, within Spain. So, and it's thinking from the focus groups is what came out of that. There was issues that actually we've been discussing some of these today. And it's thinking about that at the moment, social prescribing is fragmented, but has significant potential. But it needs grassroots initiatives addressing sustainability and integration. There's a need for collaboration, awareness and training, for critical scaling up efforts. We need to address the barriers due to limited coordination, training, and also geographical disparities. We need to standardise training for health and social care professionals. We need to develop toolkits, and we need to impact on policy. So we need policy templates and training programmes. We need to build cross-sector partnerships and digital infrastructure for referrals, and also develop national frameworks and legal recognition for social prescribing. And it's also importantly, is the increased funding for non-clinical services, because some of the organisations, they're being referred an increased amount of people, but they haven't got the funding to actually manage that. And it's important to raise public awareness about social prescribing and to test volunteering integration into cancer care. So whistle-stop tour there. So in actual fact, so then we actually did a survey across Europe, but actually we got some responses from outside of Europe, but we actually got responses from over 37 countries. So, so as you can see, there's a wide range. Malta was at the top, and the UK, but also we got responses from Albania, Armenia, Austria, Bulgaria, Estonia, Finland, Latvia, a whole range of countries. And it was good in a way. They actually were aware, the majority were aware of social prescribing, and they were familiar with the concept. And they agreed with the definition provided. And it's thinking about the perceived helpfulness of it, considering very highly and useful context for cancer recovery. And it's thinking about the awareness of the green social prescribing, but it's something that's emerging. We need to work at it to take things forward. Especially thinking about the rehabilitation of cancer patients. So we also need to think about how we can actually work that in with community-based activities and think about the volunteer involvement. And it's also thinking sometimes differently in the idea that it's not they're going to a garden, they're actually going to volunteer to work in the garden. So it's not as if they're just going to sit there and do nothing. So so there's a strong interest from across Europe in this initiative. So the way forward we're looking at within the programme is thinking about future training and training materials. So what is being developed at the moment within the SPACE project is the development and piloting of online materials to provide a comprehensive approach to train health, social care, rehabilitation professionals, as well as civil society organisations. And then we're going to be testing those materials with cancer patients that are recovering, and also health and social care and rehabilitation. So this is going to be across the 5 participating countries at the moment: Spain, Greece, Malta, UK and Ireland. And then it's proposed to prepare a policy brief aimed at education and training and across Europe. And also this is going to be evaluated. So if you want to follow us, you can follow via social media on the what is going on with the project as it's developing, and that would be good. And also, if you want to, you can join the Social Prescribing and Community Orientation Special Interest Group within Wonka. Whistle stop tour. Okay, that's just the definition that was used. Was I too fast?
No. Thank you so much. Just perfect in time, because now we have time for 3 minutes for questions from the other
participants. A lot to
participants.
go through.
Yeah. But it was very, very interesting.
Yeah.
Again, another perfect example of what social prescribing can be, and different target groups for it too. I haven't seen any question in the chat. You just put them there if you want to.
There were so many questions this morning, and then there haven't been. So please, the attendees, please write more questions or repeat them if those you wrote in the morning, because I can't remember all questions. Very many relevant, I think, questions. Ferdinando, you agree, and Paula and Klaus.
Yes.
Yeah, Anita. Yeah, Joyce.
And as you wrote in the chat, we will copy that and send it out to.
The chat will be saved and copied. Yeah.
Yeah.
It's just thinking about, how there's a different groups that would benefit from social prescribing in different ways.
Yes. And even though there's so many studies who's indicating it's a very good way to go, we need more evidence and more designed studies that really can see what's happened and maybe control with a control group and so on.
Yes, the one with the randomized control trial run by Wolfram Herman is going to be a large randomized control trial looking at different populations.
Interesting. Now we have 2 questions. Any connection with international organizations like WWF is one question.
Not
for
at
you,
the moment, but
no?
I think one of the benefits of the working within the World Organization of Colleges and Academies and Associations in general practice is the potential links across the different countries with different organizations, and also it gives advice to the WHO.
Okay.
And especially for rural communities.
Great. And then we have one more, and then it's next speaker. Herr Julia, I guess I have a general question still about how long the social prescription lasts for, what follow-ups occur during the process, and when is someone discharged? Is her question.
They haven't. It's open at the moment because they're looking at the training program. So we're only really at the beginning of the research project. So
is it?
Sorry.
Is it for 1 week, for 10 weeks, or are they in there for how long as they want? Or
at the moment, it's open.
Okay.
So it's actually really looking at what training is needed for the needs of the patient recovering from cancer.
Okay.
So it might be we're going to find out during the project what their needs are, and especially following the after effects of treatment. So we've got to take all those things into consideration.
Okay, great. Thank you so much. Oh, that's my fault. Now it's 46. Now, thank you so much, Joyce. And now over to Ferdinando. And you will talk about the Delphi study about the link worker. We have so much questions in the first part of the program about link workers. So welcome to answer all of these.
Okay, thank you very much, Paula. Hi, good afternoon to everybody. So just let me introduce myself. I'm a rural doctor working in a solo practice in southern Italy. And I'm also a member of the Social Prescribing and Community Orientation Wonka Europe Special Interest Group, along with Joyce Kenkre. Joyce is the chair of this special interest group. So very broadly speaking, who is the link worker? Is a professional, let's say in most of the cases, non-clinical professional who connects patients to local community groups and services to improve their health and well-being. He or she acts as a bridge between the health and social care, providing a non-clinical and personalized support. Sorry, okay. We have realized that so far there was a lot of a way in this in the how this figure, the social the link worker, was involved in different countries. That's why we started thinking, okay, we need to make some research on this. And actually, we decided to perform a Delphi study, also because we were inspired by the Canadian study by Kathleen Muhl, who you have listened to her presentation in the morning. So we decided to make a Delphi study on the role of the social prescribing link worker. This is the list of the panelists that we've involved. So panelists, of course, should have been people who were involved in the social prescribing activity, either as researchers or as link workers or doctors, where the social prescribing activity is performed. And there are other eligible criteria that you can see at the bottom of these slides. So people who are involved in also this organization on social prescribing. So 75 were actually the people who were involved in the first round. As usual, you know that when you have different rounds in the Delphi study, you have some sort of attrition. So you lose some respondents on the way. But actually, in this case, we managed to have quite a good number of respondents, and we didn't lose anyone from round 2 and round 3. In this slide, you can see the country where those respondents came from. Of course, UK was the most popular country, but not only UK. As you can see, Europe is very well represented. It is mainly a European study funded by the EGPRN. EGPRN stands for European General Practice Research Network, another network of Wonka Europe. So just I want to show you this figure that illustrates the methods that we have applied. 3 rounds. The first round is just an exploratory mapping. A participant completed an open-ended survey to map current practice and generate statements. At the end of the first round, we have prepared 52 statements, and the respondents were asked to make an agreement according to Likert scale: strongly agree, or neutral, or don't agree, do not agree at all, the usual Likert scale. After the second round, we had the third round. So participants were invited to respond to 19 retated statements and finally have rejection or approval of the statements. We must say that we adopted this threshold of 80% of approval or rejection, which is quite strict. And I will show you that this may be not as cost problem, but it's interesting to see that although sometimes we have to reach the threshold, but we were almost there. So what is interesting, round 2, this is a consensus overview, 52 statements across 6 domains. 19 of these 52 reached the agreement. 1 was rejected. There was a strongest consensus on the actual role and the job description of the social prescribing link worker. There was a lowest agreement in, actually this was completely rejected there was a proposal to make replace the social prescribing worker with an app. This was completely rejected, but also we didn't find a good agreement. We didn't reach the consensus on the way the system works, especially in terms of funding the activity. So yes, no consensus. As I said, the funding and the employment models, especially for the link workers, we didn't find an agreement on this. We also didn't find an agreement on the professional background or certification, but you will see that we were almost there. On the self-referrals and some referrals route, and as digital tools for to replace the link workers. In round 3, 19 statements were rated, 13 were approved, 2 rejected, and 5 remains without consensus. But we need now, okay, round 3, in the round 3, there was extended consensus of in the job description, optional accompaniment to activities by the link workers, the first step support for urgent social problems, data collection with consent from the patients, and on the context-sensitive fund principle. So in each country, the funding could be different. And we can go in these slides more in depth in the description of the job the job description of the link worker. So the link worker explores what matters to the patient. The link workers should support patients in navigating services related to social needs. The link workers could include collecting social demographic data, etc. We don't have time, of course, to read all this statement. I must say that this article is almost ready to be submitted. So hopefully in a few months, you can read the articles. But what is interesting that look at this line highlighted in yellow. So there was an approval of 97% of the people said, okay, training is important, while only 77%, and that's why we didn't reach the threshold, said that it was important to have a common background in this field, the social work, nursing, education, etc., etc.
Time to round up.
Sorry?
Time to round up.
Okay. Certification was also did not reach the consensus. So the overall interpretation is there is a clear consensus on what social prescribing link workers do, and there is less consensus on how the system should organize them. Okay, thank you for being so attentive.
Thank you so much, Fernando. It's so small little time, but we have this open space afterwards, and when we can lift some questions there. Very, very interesting. And now we go to Daniela Royats, who has also been involved in the presentation of the WHO report about social prescribing in different healthcare settings. Welcome, Daniela.
Thank you very much for the invitation. I hope you can see my screen now and the presentation.
Yes.
Thank you. Okay, so I will start showing you the definition we saw earlier in this conference, the social prescribing definition by Caitlin. I don't want to repeat it again, but I just want to highlight one piece of this definition, and it's social prescribing is a means for trusted individuals in clinical and community settings. So it means that social prescribing can happen in different settings, and that was also our starting point for this piece of work. And this was within the framework of a WHO collaborating center, the WHO collaborating center for health promotion in hospitals and healthcare. So you see also different healthcare settings in our focus, and we have in our focus of work in the period, we have 2 work packages on social prescribing, to do webinars on social prescribing and do a technical brief. And this technical brief I'm happily to present today. And we see social prescribing as an innovative approach to strengthen health promotion in healthcare in different settings. But we want to have a deeper look, what are the similarities and differences of social prescribing in these healthcare settings. So we had a look at 3 to 4 ways of doing social prescribing or settings. We had social prescribing in primary care, which might be most familiar with all of you, but there's also social prescribing in hospital setting. Then there are the little bit maybe confusing thing, community-led social prescribing, that is, in our understanding, social prescribing based in the community, but the community organization reaches out to the primary care setting and says, please have a look at other elements than medical care, because they are also important for health, and then they cooperate. And there is, of course, another form, that's community social prescribing. So when a community health center or something like that also offers social prescribing. And there was a 5th form we do not understand as social prescribing. We called it social connectedness. That means we are not in the space of primary care, but in the space of lay care or community care. So where maybe 2 women meet at the playground and talking about their kids, and within this talk, they find out that the one kid needs some more leisure activity, and the other mom says, okay, I need this soccer club and please go there. So that's really just from one people to another with no health professional or link worker in between. So we do not understand this as social prescribing, but call it social connectedness. This is important, but we do not understand it as social prescribing. So we focused on these 4 ways of doing social prescribing in different settings: community social prescribing in primary care, and in hospital care. So what are now the differences and similarities we found? I start with the similarities. No matter in which setting we look at, it is a holistic and person-centered approach focusing on individual needs. So what matters to the patient, not what's the matter with the patients, which was also told earlier in this conference. Then it's about promoting health and well-being in settings, especially in a community setting, because you refer to these settings and this community assets. It's about referrals to health promoting community-based supports and services, and it's about empowering individuals and helping people to get control over their health. What is different depending on the setting is who identifies the need. Is this a community worker? Is it a GP or somebody in primary care? Or is it a surgeon at hospital? And of course, the accessibility is different. So you do not go to hospital usually if you do not have a real hard health issue. Whereas you can enter primary care or especially community centers offering social prescribing if you do not have a real serious health issue. But and of course, the target group is different. So with community social prescribing, you can be more close to the community than, for example, in the hospital setting. But you have also different people you will see there. And also the link working might differ a little bit. Who does the link working? Is it as a health professional? Is it a less trained person? And also how the referral system is differs, because also the outreach area where the network is depends if it's a hospital with maybe a large region they cover, or it is a primary care-ish setting, which is little bit closer. So there are the differences. So coming to an end, social prescribing supports, no matter which setting it is, the shift towards patient-centered, preventive, and health-promoting care. It focuses on what matters to people, strengthening social participation, and it is a flexible, value-based approach which is adaptable across settings and also healthcare systems. It reaches people where they are, especially those underserved by existing care. So, and also we have also heard earlier by Ferdinando that there are some things we had to clarify still. So clarifying the roles, especially the link working, who is the link worker, which training is necessary, how is link working done, etc. But also ensuring the quality of the regional assets where we refer patients to, and we need more understanding what works for whom. And I will conclude with the statement that social prescribing is not a question of the setting, but a function which is there for the people who need it. And it's not important if it's in community, primary care, hospital. In an ideal world, social prescribing should be offered everywhere so that every person had the chance to be in contact with one of the settings to get the help he or she needs. And another aspect I want to point out is that we can also learn from the referrals to the community assets, because we can also have their feedback and support learning to further development, not only the link working process, but also the community assets. So it could be really a loop of learning for all of these parts. Yeah, if you want to know more about our work, it is published. I have shown you the QR code. Please scan it and read it. We have also the webinars we did online, so you can have also look at this. And just a short spoiler, coming back to Austria, we also try to implement social prescribing and learn how it can work out in Austria. And we will start a new implementation phase with 30 facilities in March. Thank you very much for your attention. And if there are any questions, I'm happy to answer.
Thank you, Daniela. Yes, there are. There are a question here. It's about in the hospital, are there social workers in the hospital? Is social prescribing not mainly embedded in the social ecosystem, and the link worker pertaining to the community, is the question.
Of course, there are social workers in hospitals, and there's also this question: what is a link worker? What is social work? We had also this in our discussions, but there are also link workers in the hospital who can refer to community assets.
Okay. I hope that was an answer to that question.
Kathleen Muhl, are you with us, Kathleen? She told us in her presentation that she was doing social prescribing. She was starting in a hospital setting, so maybe she could answer some of that. What she's.
Are you there, Caitlin?
Maybe she'll show up later. Okay, otherwise we have some more time actually, because it's not until 10 past that Klaus should start. Klaus and Millie from Denmark. So there is more questions. I reflect on one of the comments from Julia. She talked about social muscles. You should flex your social muscle. That was very interesting. Did you read that, Daniela? Yeah. I've been thinking about that. Yeah, flexing your social muscle. Yeah. Maybe Julia, you could write something in the chat here, because I don't think the attendees can talk, are able to talk here in this in the webinar. But
I was writing in the chat about the Delphi study, Ferdinando's Delphi study, that is maybe need to be clarified what was not approved upon and what was was approved on, and we don't have the time in the open plenary. So maybe you can clarify now just for 1 minute, Fernando,
Yes,
about
Fernando,
that.
please.
Yes. Okay. What is important that unfortunately I pressed the wrong button before I think you can read. So the training in empathic communication, active listening, motivational interviewing, etc., was approved with the 97%, sorry, while the educational background was approved only by 77%. I understand this, that it is not important your background. Just let me to explain that you might have become social workers or nurses or something else many years ago. You haven't heard of social prescribing. So it is a more actual training that is more important than your educational background. I understand this from the different in the responses. This was the main points.
Okay, so but we have heard. Sorry.
No. Please go ahead.
Yeah, so that confirmed what we heard earlier today, that it doesn't matter the education, but it has to be a person who can talk to people and be empathic and so on. So,
a good
so
listener,
that was not
a good listener. Yeah.
Yeah. So that was not a bad thing, maybe, that you not agreed upon the education.
Yes.
It showed that it doesn't matter. Yes, we have 2 minutes left, actually. So you are so splendid, all of you, to keep in time. But no, I can't see any more questions. And then we can just give the words to Denmark. And now we're talking about short time because Klaus and Millie are going to share their slot for 15 minutes. So welcome with the examples from Denmark and social prescribing.
Thank you. My name is Klaus Rantorff, and I'm a part-time GP in the central Copenhagen, and a member of the board of the project Social Prescribing in southwest Copenhagen. You talked about social muscles before. Maybe I will talk about to be social rusty. That's a problem that's a challenge in our project. We use the word in Danish, social henvisning, translated in English, social referral, because referral is a more active process. A pill is a pill, but referral needs reflection, decisions, and communication with the patient. So therefore, we have decided to use referral as the translated word for prescription. Yeah, shift please, next. Yes, thank you. The area, southwest Copenhagen, is very diverse, and originally it was characterized by heavy industries and a labor population. But this has changed as in a lot of other European cities. So now, shift, please. Next picture. Thank you. And next again. So today, the area is more characterized by apartment buildings, service industries, and office buildings, and a mix of amusement, restaurants, and Tivoli is there. So a lot of tourists come in the area. Next picture, please. Next, yes. The richer part of the population live in the harbor area, where There's a lot of the population is characterized by students, higher educated, families with children, and the older generation lives in the south part where the more deprived social groups are living. Next, please. Next picture. Thank you. In the area lives 92,000 inhabitants, and they are serviced by 50 GPs in 20 surgeries. And we have engaged 2 link workers which work together with 50 volunteer organizations and 4 projects managed by the municipality of Copenhagen. I have come here, social prescribing in Southwest Copenhagen is the first great-scale social prescribing project in Denmark. There's some smaller ones in Roskilde and in a place in Jutland. Next. Yeah, this is our secretary, this house here. It is a beautiful place in the south part of the area. Next, please. We are 2 doctors in 2017 which got the idea to introduce social prescribing in Denmark. So we took a pilgrim trip to Frome in South England and got inspired. And in connection with that, we got into connection with the Danish Association and the Cooperation of Volunteers organizations in DK, which have visited Frome too. So Frome was, they brought us together. So we are the partners now in the project. We have made a collaboration with the research department in Hillevi Hospital, which make a mixed method study of the project, both quantitative and qualitative research. We only have few qualitative results now, and quantitative research has just begun. So next picture, please. We are funded by the public Ministry of Social Affairs and Housing, and some private funds, Novo Nordisk Foundation and Truck Foundation, and some smaller foundations. Next, please. Our target group is loneliness, chronic diseases, social vulnerable people, and mental health challenges. I have to tell you that the project is a part of the national works against loneliness in Denmark, and we have the same problem as in other European countries, that we have a growing population of lonely people in Denmark. They have estimated it to 9% of the population, which is more or less lonely. So the project is one of the target is to take care of the lonely people in the area. Next, please. Bit about the story. The project started in May 2024, but we only have a small foundation funding from the Ministry of Social and Housing. So there were only 6+ population which were included. In 2025, we expanded to the whole grown-up population because of the funding from Novo Nordisk Foundation. And today, nearly 200 citizens are referred to the project. 33 are in the link working phase, and 45 is connected to community projects, and 4 are working as volunteers in some of these projects. It's estimated we have planned that the project should end in 2027 if we don't get more funding at that time. Next, please. In the work with social prescribing, the 1.5 year we have worked with that, we have we have found out that there are some challenges for the work with social prescribing. The World Health Organization had made some publications about that social well-being is a missing pillar of health, and that is correct, because we have problems to get the understanding between the GPs in the project that we have to take care of the social problems in the patient's world. Another problem is that we, in general practice, we work a lot with reactive problems in our clinical work. We have a growing burden of work with patients with chronic diseases and multimorbidity. It is estimated in Denmark in 2030 that 40% of the population will have one or more chronic diseases. So we have to get rid of this burden if we shall have the possibility to work with proactive issues as social prescribing. And the last bullet, we have in our project sense that not all patients are ready to community projects. They are too rusty to get into groups, so they have to be taken care of in a longer, maybe therapeutic or more creative way. Next, please. We have the problem in the project that some doctors, they don't feel that the social dimension is a part of their work. They tell us that they are shy to talk about social problems and especially loneliness. And some of them say that they don't have the words for the communication with the patients. So I think we have to re-educate some doctors to realize that the social dimension is a part of their work. A new wave in European health theory is generalism, so maybe we should learn the general practitioners to be generalists again. Next, please. About the burden of chronic diseases, we have to, if we should change to a more proactive way of work in general practice, we have to make a more tailored care for patients with chronic diseases. The most competent and autonomous patients maybe should have another kind of care than the patients with social issues and the patients with multimorbidity. Next, please. As we have found out, around 20% of the referred participants in our project are not ready to community projects. So we are going into collaboration with projects which have a more therapeutic and a more creative way of working with. So I can agree with that. We have to have green social prescribing in our area too, but we have not built out to these areas from now. But this is a future project for our project in Copenhagen. But now I will give the page to Millie Keeney Jensen, which will talk about art on prescription.
Thank you, Klaus. I will present about the public health programs in Denmark. I am a public health consultant here in Denmark, and I will briefly explain the different types of public health programs we have here. Next slide, please. In Denmark, we have a huge tradition for small community associations or community clubs, and they're found in the smallest of villages to the larger towns. These clubs tend to have activities such as football, yoga, gymnastics and handball, and as health professionals who focus on health promotion and physical activity, it's quite easy to refer patients to join these clubs or refer them to Nature and Prescription, as these are accessible for all. And we know that many of the citizens have very good positive mental health and well-being effects of such activities. However, in all countries, just like in all countries, there is a certain amount of citizens that are not physically active, and such a recommendation will never be acted on. And I think Andreas also referred to an article today by Margaret McCarthy that highlights this, actually. And also citizens that have poor mental health, and we often find it a task to join such clubs. As Klaus was also in on, there is some socially vulnerable citizens or citizens missing social skills, and this creates health inequity, that they have no alternative programs. And therefore, because of people not wanting and not being able to do physical activity or not being interested in physical activity, there needs to be other types of health promoting programs. Change the slide, please. And this is where arts and prescription comes in. Arts and health has been a growing area for quite a while now, and we are seeing very positive effects with such health, with arts as health promotion programs. Arts and prescription in itself is a relatively new concept in Denmark. The first pilot began 10 years ago with funding allocated to assist socially and economically vulnerable citizens. And Danish arts and prescription programs have remained heavily inspired by the programs that we have seen in the UK and Sweden. Aalborg municipality, alongside 3 other municipalities, were the first to pilot the AOP programs in Denmark. And since that, Aalborg has created a sustainable model called Cultural Fishermen's, and we are seeing also other arts and prescription programs all over Denmark, in Silkeborg and in Copenhagen municipality, and the 9 municipalities on the island of Fyn have implemented numerous AOP programs, offering AOP to diverse target groups. And funding differs from place to place. Sometimes it's the municipality, and sometimes it is funding through calls in the fields of culture and health. I will briefly tell of our experience here in Denmark. I will, as I know Paul and Nita will be sending more about scientific findings from their AOP studies. AOP here in Denmark has been primarily targeted to people with stress, anxiety and mild to moderate depression, or citizens experiencing loneliness. It is an 8 to 12-week program, group-based, with 10 to 12 participants who participate in cultural activities 1 to 3 times a week for 2 or 3 hours at a time. Change slide, please. The participants often find it as an alternative or supplement to conventional health or mental health programs. And common for all AOP programs is that it's a non-therapy approach. It offers a diagnostic-free room and where the person is in focus and not the reason why they joined the program. And again, citizens that are socially or mentally vulnerable can benefit from AOP programs, as they can speak about the works they have created or the museums they've visited. In that way, they don't have to share any personal stories. It's also important to mention participating in such cultural activities. It is not so much about the result, about what one has painted or one has created in pottery, but it's more as the process of painting or of singing or dancing or making this pottery or writing exercises, example, in literature activities. Most of the participants have not previously involved.
One minute.
Most of the participants have not previously been involved or have experience working with the arts, and therefore they have this unexplored creativity that comes forward. And various reports from the Danish programs have shown that the participants have experienced more self-worth, self-esteem, and a sense of social belonging. And we've also experienced that participants have continued meeting after the programs. And we know on the island of Fyn that people have been meeting 2 to 3 years after they have participated in the arts and prescription programs together. And very, very briefly, I will mention, if you want to know more about arts and prescription, there is 2 initiatives at the moment. And one is Charlotte from NASP hosts the International Arts and Prescription Collective online meeting every 6 weeks. And we also have an online AOP guide developed by the partners of the Arts and Prescription, the Baltic Sea project, where Odense municipality here in Denmark has been lead partner. And the AOP guide is for decision makers, culture and arts facilitators, and public health professionals who would like to learn more about AOP and implementing such programs. It is at the moment being presently translated into Danish and Swedish. And I'll put a link to the guide in the chat. And thank you very much for your time.
Brilliant. We must move on now. We have no time for questions at this time. So please, Paula Bergman and Anita Jensen, talk to us about arts on prescription, more about that, examples from Sweden.
Yes, thank you so much. And I'm a PhD and a public health developer in the region Jönköping County, and I will talk about our experiences of more than 10 years with arts on prescription and our model and the research result. Next slide. And just shortly about the model we have done research on. It's arts activities for 2.5 hours twice a week for a duration of 10 weeks. And the participants meet 6 different artists leading various art activities. It's dance, singing together, it's going to a concert and theater and crafts and painting. Yeah, it's various, and it is conducted in closed groups. So the groups follow each other for these 10 weeks. In our model, we have no leader who follows the group every session, but join about 3 sessions. So this is the group who is the safe room, so to say. Next slide. And the collaboration model is also a financial model we have been having these 10 years. And we have a county coordinator from the region. It's put on the Central Public Health and Healthcare Department. And then we have the rehab coordinators in the region from the primary care units and the outpatient psychiatry units. And the role from these is to talk with their colleagues, so they also can refer to AOP. So it's not only the rehab coordinators who refer. And then we have a very important person, the AOP coordinator in the municipality, the local AOP coordinator. And these persons put together the AOP program, have contact with the artists and the participants and those who prescribe AOP from the healthcare. So this is a very important person. And then we have the arts professionals who facilitate the arts. And they could be free professionals from the municipality or for the region or for community social organizations. But they have to be good in the arts and in how they meet people. The next slide, please. And now time for some results. And these results, it's a study population from people who are 18 to 66 years and on sick leave due to common mental disorders and or long-term musculoskeletal pain. And the study population contains of 350 participants who had been involved in AOP program and 250 participants in a control group who had been on sick leave for the same diagnosis. Next slide, thank you. And I just present these 2 studies, published studies. The first is about the effects of arts on prescription for persons with common mental disorders and or musculoskeletal pain. And it's a control study with a 6 and 12 months follow-up. And the results show that was a significant decrease in both groups. So the healthcare is doing very good also. But there was a greater effect size as a bigger change in the AOP participants group for stress, anxiety, and depression. And in depression, the difference between groups was significant, not only bigger effect size. And the other study I want to talk about is analysis about the effect or the influence of sense of coherence. And it's the same design, follow-up 6 and 12 months after and compared to the control group. And also here we could see a significant increase in sense of coherence for both groups. And here we want to have the increase because it's good to have the sense of coherence. And there wasn't a significant difference between the groups, but there was a double effect size, a double increase for the AOP group compared to the control group. So it was more difficult to have this significance in this measure. And finally, I just want to I just have a question. What is intervention in the control group? Oh, sorry. They get the usual care. They have they have conversations with counselors, and they go to physical activity, or they have CBT or different. What's usually given to these diagnosis groups? Sorry, I didn't tell about that. They get usual care. And the last, we can change to the last slide. And now I just want to stress that this is preliminary results. So it's not published and it's not reviewed, but when I have this, I have to show it anyway at this occasion, I think. And it's the same population that I talked about before, and it's follow-up after 6 and 12 months compared to this control group who was given usual care. And it was very exciting when we saw that there was a significant greater reduction in sick leave in the AOP group compared to the control group. And the difference was moderate. It was a moderate between group effect size. So it's it's quite big. And when we analyze the return to work after AOP or after usual care, there was no significant difference between the groups, but also here there was a bigger effect size, the bigger change in return to work in the participants who have joined the AOP compared to the control group. So it was a moderate change in the AOP group and a small change in the control group. But this is only preliminary results, but look out for the published ones coming maybe this year, I hope. And I think that was my last slide. So I give the word to Anita.
Thank you very much, Paula. I am just trying to share my screen. I think that's successful now. Can you see it?
Yes, you see it. It's good.
Thank you very much. So yes, I'm also going to talk about arts and prescription in a different place in Sweden, in the south, in Scania. My name is Anita. I work as an arts and health strategist in primary health care, and I'm an associate professor at Lund University. So we have conducted a 3-year study on arts and prescription for primary health care patients with mental health problems, and we also included those who were socially isolated and lonely. And the overall result has shown that arts and prescription can be a catalyst for change. Specifically, we found that that there was a significant increase in well-being and salutogenic health. And also women and the most vulnerable participants experienced the greatest benefits. We saw that patients reported to have more social contacts and increased sense of community connectiveness, as well as benefiting from the structured activities as they help to create some routines in their lives. We saw increased activation among the patients, and they also reported better self-efficacy. They reported a shift from being ill or from illness to a more can-do attitude. So based on the positive results, a political decision was taken by the Primary Healthcare Board to finance the implementation of AOP across the region as a primary healthcare initiatives for patients with psychosocial problems. So now we're implementing in 33 municipalities, working with 181 GP surgeries, as well as continuing the research, conducting a longitudinal study measuring effects on depression, stress, anxiety, well-being, and loneliness over time. And we're going to include a control group. We also see this as a platform for social prescribing where other activities can be added in time. So the referral process looks like this. It's based on a medical assessment, and then a referral is made, and that can be by a GP, it can be by a nurse, a psychologist, or another healthcare professional, and is part of a person-centered healthcare plan. And when the referral is received, the Arts and Health Pilot, as we call our link worker, contacts the patient, and this pilot is employed at the healthcare center. The patient attends 10 weeks, twice a week, for about 2 hours in a group, and the pilot also attends the activities with the group. After the 10 week, there's a follow-up with the healthcare provider, and there is a continued care activity, which is locally, and it's usually on drop-in basis. There's information available for patients at all medical centers, as well as we have an AOP contact person at all the medical centers that are involved. Findings from our systematic review and a meta-analysis on arts and prescription, which included 25 studies from across different countries, shows a significant increase in well-being, but it also highlighted some of the important barriers for practice, which identified as physical. So that could be transport being too expensive. It could be language. The spoken language was difficult. Mobility of the patients, or them simply being too ill, which somebody else talked about earlier also. And also the accessibility, it might be too far to get there. In terms of psychological barriers, engagement, difficult to engage in the art. Some patients prefer medical solutions. Some consider art as being elitist. Some of the social barriers could be that the group was too small, it was too big, there was a negative group dynamic. But there's also still stigma attached to attending groups for mental health, and especially in some cultures. We also saw that there were some systemic barriers, the lack of awareness among healthcare professionals that this was available, support at the end of the program for the patients. We heard from patients that many started feeling anxious about the uncertainty of the end of the program, what's going to happen now, what's available for me. And also the sustainability, the fundings of the art programs that we are referring to. In terms of cultural dimensions, it needs to be culturally relevant for the individuals as well as age sensitive for the patients. Just remembering one size does not fit all. And we found that the facilitator is the skills and the competence of the facilitator is imperative. It can make or break the group. And I think that's all I have time for now.
Thank you so much, Anita. Thank you. So that takes us to the final part of this before I say goodbye to you all. It's Margareta Christensen, professor at Linköping University. Please lead the open plenary from evidence to practice, key messages for advancing social prescribing in Scandinavia.
So much. And then I want to welcome the panelists who you can see here, the names. Those are Joyce Kenki, Daniela Rogers, Catherine Muhl, Fernando Pertatusi, Claes Randhoff, Mille Joy Kinsen, Paula Bergman, Anita Johnson. The major part of the afternoon session, but we also have Kathleen Muhl here. I'm a professor in social and preventive medicine, and I have the honor of sharing this. I do have some questions by myself, but I wanted to start maybe with one of the last questions in the chat, and that was about vulnerable patients. How well is social prescribing rusted to manage very vulnerable individuals? Who want to comment on that? Because we know that social vulnerability and medical vulnerability are very close related. One question stated it as is the social connector skilled enough to handle medical problems? And what is your response to that?
Susanna, you raise your hand first, please.
Susanna, you're allowed to come in.
I wanted to comment on the vulnerability question.
Yeah.
Since we have this Christine, she's an amazing social educator working in the healthcare center together with the healthcare professionals, and her major focus is on the mångsökare, people who are calling us all the time, going to the doctor for various symptoms and things. And she has been doing wonders with these people, and they are often in a very vulnerable situation in their lifestyle. And this is she's doing this individually in the beginning, helping them to solve different kinds of problems and getting to know them. And some people then are happy to join a group or something that is arranged in the local community. But it's absolutely possible to work with vulnerable people, but it's not just here, it's a prescription, go to this group. It's individual person-centered work that needs to be done. Close collaboration between the healthcare professionals and the link worker who is not medically schooled.
Klaus, do you want to go on this question?
Yes.
Maybe Anita raised her hand before, so maybe.
Okay.
Yeah.
Anita first. Yep.
Anita first.
Thank you for your fairness, Hans. I just want to say, yeah. Of course, there's many participants who has multiple problems, and some are medical, and some are there sort of more vulnerability. The way we try to sort of combat that is that in the initial assessment at the medical center, the doctor or the psychologist also looks at that. You know, is this somebody who can actually attend and can be part of a group? And then we our pilot, which is the support person who goes on all the activities, looks sort of make sure that that their needs are met if they have special needs. And in addition, we also train our cultural actors or facilitators in mental health awareness, so they kind of know the population that they're dealing with. So that's just some comments on how we do it here.
Great. Thank you, Anita. Klaus, do you have any comments on that? How do you deal with your sickest patients who are both somatically and socially ill?
We, in our area, we have some activities which work with people with mental illnesses, but a lot of these vulnerable patients don't define themselves as people with psychiatric diseases, so they cannot get care from these. They don't want care from these activities. But our linguist is very aware about this, and they have made a special group for a built-up group for mental vulnerable participants in our project, and they meet once a week and drink coffee, and they are building up their mental strengths together. And our link worker says that they can see they grow slowly in company with each other. So that's one of our solutions. And we have a psychiatrist in the area. She have made a writing group for people with mental vulnerability, and there are good research from that, and they are making research on that group. That's my comment.
Thank you.
May I, as a moderator, have a question myself? My research has since many years been on the role of psychosocial factors on risk of somatic disease, such as coronary disease and sudden death. And we know that people with psychiatric disease or loneliness and social isolation have much higher risk of somatic disease. They died 20 years earlier. And can I ask you, what we have talked about is the risk of medicalization of social problem. Could there be a risk in the other end that we tend to neglect medical problems and go too quickly onto this social solution? Who wants to comment on that?
I can say something quickly. I think that depends on where the referral is made. If it's made at the GP surgery, then of course you need to do the medical assessment on this person. But if you're sort of referring from other places like a social worker or some voluntary organization, then maybe the medical factors are neglected.
Fernando and then Klaus.
Yes, and I agree completely with Anita that here the role of the GPs is important, the primary care doctor. In our project that was illustrated by Joyce on the space project, actually in people who are recovering from cancer, who have recovered from cancer, actually, we have a special session on the evaluation if the patients can do this green activity, etc., etc. So there are some flags, red flags that say, okay, you are eligible for this kind of activity or not. So if we are talking about physical vulnerability, this is one point. If we are talking about other vulnerability, for example, social vulnerability, I want just to tell you that there is another project, the SVU project, where social prescribing will be used in people, migrants, and in LGBT plus population. And in this case, the issue is the recruiting these people and how. Because sometimes there is a stigma associated with this condition, and it's that there is the problem that patients cannot volunteer to be involved in this kind of activities.
Thank you, Klaus.
Yeah, Margareta, I have never heard that that's a problem, that we can overlook somatic diseases when we refer socially, because as Anita says, in our project all the patients are referred by general practitioners, so I think they have had these thought primary that maybe there's some somatic issues. But as I have heard is that when you get into these community projects, some of these patients get more self-confidence and more strength to follow their health so they can, maybe some of the other people in the community project can help them to go to the doctor and begin to use the health security system. So as I heard, the opposite is the case, that people in social prescribing can use the health system more differentiated than before.
And,
but it's only what I've heard. I have no evidence for that.
That is why I believe in this, but there is a lot of evidence, for example, in emergency departments, etc., that patients seek again and again, and when the physician or in primary care, when the physician identifies, well, this is a psychiatric disease, oh, this stomach problem sits in the head, I don't do anything more. So there are very much prejudices on patients with psychosocial problems. But I do think that the concept of social prescribing is to look at this in a holistic way. So I do believe, Klaus, that this is very good.
Yeah, and it's important that the general practitioner and general practice is a core area in social prescribing.
Yeah, absolutely. So this is what Susanna always says. It has to have a core link to the primary care. Now we have 4 minutes, and you are 8 persons. I sent you questions on the mail. Now you have half a minute. Who wants to start? What is your take-home message to people? What is most important to make social prescription develop and be as good as it can? Who starts?
I can start. Oh, sorry.
Mila has a hand up.
Yeah, it's because you just left it at that with Klaus saying that the GPs have to be at the centre of this. And when we're talking about advancing social prescribing in Scandinavia, which was the question, I very much back what they've done in the UK. Charlotte spoke about that the social prescribing is part of the GP's contract. And if this becomes part of the GP's contract, then it can be rolled out at a much quicker and larger scale.
Thank you. Good. Daniela, 30 seconds.
And I think my take-home message is that there are many resources, and I think that's the very heart of social prescribing. Do not look at the deficits, but on the resources. And if we are still be connected on every level, on the GP patient level, on the community asset and medical care level, but also we as internists and scientists and practitioners on social prescribing, that if we all work together and just have the spirit of using synergies and resources, I think we're on the winning side.
Good, focus on resources. Joyce?
I think it's about having conversations about opportunities there are in the community, but also to develop and use evidence to impact on patient outcomes and policy.
Anita?
I think we need sustainable structures where municipalities, primary healthcare and civil society collaborate, underpinned by policies and a system that ensures quality of activities.
Thank you. Very good. And Paula, is you the last one? You have the concluding remark.
I don't. Yeah, not the concluding, but I just agree with the.
I don't need all those minutes, I think, so you can go on.
But I agree with what you all have said. But I also think that in Scandinavia, we need to go the path that the UK already have done. That we have to get this social prescribing within the healthcare system and improve the knowledge that this is one strong way to facilitate for many people who have complex problems. Thank you.
Fernando, did I give you 30 seconds?
No, I raised my hand, but then automatically it was down. No, but I just want to say that I agree completely with Paula. Usually in the past, we thought that the system in Scandinavia was one of the best in terms of the social activities. now maybe we have to readdress this optimal system towards this new innovative strategy.
And Klaus, did you have your time? Did you get your 30 seconds? No?
No, I didn't say anything, but take-home message to me is that we have some groups in this research milieus in Denmark which say that there's no evidence for social prescribing. But as I have heard today, there is coming up broader evidence for this kind of culture between primary healthcare and the civil society. So that's my take-home message. Don't be suspicious about the evidence for this method.
Very good. That was very clear today and very, very important.
Yeah.
So now, Hans.
Yeah, thank you so much, everybody, for joining this webinar and for all the insights you have given us and for the questions and the social wrestling, or what is it? Some mentioned here, social muscle, something. So, but there is more ahead. We have the Social Prescribing Day on March 26th. We learned that. I don't know what that means, but we probably have to look it up. But then in May, we have a congress in Jönköping, Nordic Congress of General Practice. We just got acceptance of a workshop there. Klaus and Anita and Millie and I and Paula and maybe Susanna and Margareta are joining us in Jönköping, Nordic Congress General Practice, a 60-minute workshop. And then finally this year, in the 2nd and 3rd of December, Paula, you will be welcoming us to Jönköping once again. It's a hybrid conference. And the working title is Arts for Health and Social Prescribing. So that's the working title. Do you want to say something else about that conference in Jönköping, 2nd, 3rd of December, Paula? Please invite us with all your heart.
Yes, I can do that. I invite you with all my heart and all my colleagues' hearts. And we will joining, this group will be joining to arrange this conference too. And then we have more speaker time, and we have more collaboration, and we have different target groups. So very welcome, and we will soon send out the save the date. So all of these participants will get the save the date within 2 weeks.
Great.
Hans, can I give the final word to Susanna as she opened?
Susanna, yes, please.
I just wanted to let you have your word.
Yes, thank you, everybody. Been really interesting. I think that primary care needs to be community orientated, and the local community not afraid to collaborate with a local healthcare center, because it's when we get connected, that's when we can work person-centered within the healthcare center with a 20% medical problems, and within the local community with all the other social determinants of health. So social prescribing is linking primary care to local communities. And this is important because we live in a physical body on a physical map, and we can get connected through digital platforms, and but we need to use our body where we live our lives, and it's by using our bodies and spending time with other people. That's how we are shaped to feel good. So thank you very much.
Thank you. Thank you all.
Thank you. Bye-bye.
Bye-bye.
Thank you, Eleanor. Eleanor, thank you.
Thank you, Eleanor.
Yes, thank you, Eleanor.
Taking care of the tech
of
the website.
And welcome to Jönköping. And
see you in Jönköping.
Yeah, and I think, Eleanor, this recording will be sent out to all participants. Is it so?
Yes, and we will publish it on our YouTube channel as well.
Yeah. Beautiful.
Very good. Thank you. Thank you all. Have a good day.
Bye-bye.
Bye.